हेलो।
हेलो सर, गुड इवनिंग।
हाँ जी अनिल जी, गुड इवनिंग।
हाँ सर, कैसे हैं?
बढ़िया, क्या हाल चाल है?
बस एकदम बढ़िया सर। अजय अभी ज्वाइन नहीं किया अभी
कोई
तो।
नहीं,
हाँ नहीं, अभी टाइम है सर, अभी तो।
आ जाएंगे टाइम है। हाँ। तो आपको देख के ऑनलाइन में कहा चलो ज्वाइन कर लेते हैं।
हाँ
क्या
हाँ।
क्या हाल चाल है रायपुर के?
सर चल रहा है अभी तो, वही कॉन्फ्रेंस के उसमें लगे हुए सर वही चल रहा है लोग। दिन में हॉस्पिटल में काम करना, रात को फिर बैठ के ये
ये कहा,
निपटा।
आपने अपने आप को काफी ज्यादा इससे कर लिया एकदम। मतलब यू टेकन ओवर लॉट ऑफ कॉन्फ्रेंसेस एंड वन आफ्टर द अदर, नो?
हाँ, ये तो ऐसा
एक ही
हमें।
काफी टैक्सिंग होती है वैसे, मैंने मेरा पर्सनल एक्सपीरियंस है, एक करके बंदे का दिमाग एक बार ठंडा हो जाता है। अभी अब
हेलो।
मतलब मेरे तो ऐसे
हाँ, मैं कर दूंगा, कर देता हूँ। हाँ।
हाय अनिल।
बॉस, गुड इवनिंग।
हाय, गुड इवनिंग। हेलो सर। जसप्रीत सर
हाय,
कैसे?
मैं अच्छा हूँ, आप कैसे हैं?
बढ़िया
गुड
सर,
टू सी,
बढ़िया।
गुड टू सी यू।
हाँ सर, आपसे एक दो बार सर मुलाकात हुआ है, प्रोबब्ली डोंट रिमेम्बर, आई थिंक कोई एक नीरू एस्कॉन में शायद।
या आई हैव अ फेंट रिकलेक्शन। हाँ,
आप
वो
कैसे हो
आप।
सर?
मैं अच्छा हूँ, बढ़िया,
यू
ऑल
स्टिल
गुड।
लिव उडुपी सर?
या सेम प्लेस।
ओके, गुड।
This Delhi meeting, sir, could not come actually. Sir was
ओके।
in US, sir, at that
यूएस,
time.
हाँ यूएस। मुझे एक यूनिवर्सिटी ने बना दिया, मतलब दोस्त यार ही थे सारे यूनिवर्सिटी वाले भी। उन्होंने
जी।
विजिटिंग प्रोफेसर बना दिया मुझे, कहते हैं आ जाओ कुछ लेक्चर दे दो हमारे बच्चों को।
अच्छा अच्छा।
ये है यूनिवर्सिटी ऑफ सेंट्रल मिसूरी, कैंसस
ओके।
सिटी के पास ही है, वॉरेंसबर्ग एक जगह वहां पे। तो उनका जो वो एक हफ्ता था वो वहीं पे फॉल करा था उसी डेट्स में, तो मैं नहीं गया था।
सितंबर में गए थे सर आप?
सितंबर, हाँ।
आई थिंक इट इज
21 से।
क्लोज टू अरकानसा, नो?
नहीं, कैंसस सिटी से बिल्कुल पास है। जो कैंसस सिटी एक्चुअली वो
अच्छा
मिसूरी स्टेट और कैंसस स्टेट के बॉर्डर पे है। आधा कैंसस सिटी एक्चुअली मिसूरी स्टेट पे पड़ता है।
अच्छा अच्छा।
ये वहां से कोई 40-50 मील दूर है, ये वॉरेंसबर्ग। जो मतलब जैसे यूनिवर्सिटी टाउन ही है वो।
जी।
तो वहां पे यूनिवर्सिटी है, यूसीएम बोलते हैं, यूनिवर्सिटी ऑफ सेंट्रल मिसूरी। वहाँ
नाइस।
कुछ अपने जूनियर थे, वो
अच्छा
मतलब
अच्छा।
बड़े प्रेम करने वाले हो गए थे, नहीं नहीं सर आ जाओ आप। में चलो चलते हैं हम।
कुछ मीटिंग भी थे सर, यूजुअली मीटिंग के साथ वो क्लब करके
हाँ,
ज्वाइन।
मतलब ऐसे नहीं थी, उन्होंने इसके लिए मीटिंग एक बना ली पहले, मतलब
अच्छा
उन्होंने
अच्छा
पहले से बोल रखा था।
अच्छा
फिर मीटिंग जब मैंने भी हाँ कर दी थी तब, बट एग्जैक्ट डेट उन्होंने बताई नहीं पहले। तो
अच्छा।
फिर जब 1-1.5 महीना पहले उनका सारा जब हो गया, कहता जी हमने मीटिंग कर दी है और आपने आना है। और आपके 7 दिन हमने लेक्चर्स रखे हैं हमारे फैकल्टी के लिए, स्टूडेंट्स के लिए, ये वो अलग अलग तरह के स्टूडेंट्स थे, जैसे जो ग्रेजुएट हो रहे हैं या जिनको
हाँ हाँ हाँ।
मोटिवेट करने के लिए कि न्यूरोसर्जरी ले लो, दैट काइंड ऑफ क्राउड वाज आल्सो देयर।
वेरी
तो
नाइस।
फिर चले गए।
उनके यहाँ पे सर काफी ये सब होता है ना, कि हम लोग कम करते हैं यहाँ पे, कि थोड़ा मोटिवेटिंग लेक्चर्स टू द नॉन मेडिकोज या
हम
नॉन
तो
यूजर।
डीमोटिवेट ही कर रहे हैं ना, कहाँ मोटिवेट कर रहे हैं। न्यूरोसर्जरी हमें पूछते हैं न्यूरोसर्जरी कैसी हो यार, बड़ी मुश्किल है ये है वो, हम डरा देंगे जूनियर वाले को। तो हम बोलेंगे यू हैव टू वर्क 24 आवर्स, यू हैव टू डू 48 आवर्स ड्यूटी। वो पहले ही डर जाएगा, यार मैं तो नहीं जाऊंगा। तो डीमोटिवेटिंग हो गया ना।
हाय हर्ष,
बट
क्या हाल है?
सर कैसे हैं?
बढ़िया बढ़िया बढ़िया।
हाय
गुड इवनिंग
हर्ष,
सर, गुड इवनिंग,
गुड
गुड इवनिंग।
इवनिंग।
गुड
तो
इवनिंग
हर्ष
हर।
क्या आज ड्यूटी था, कोई ड्यूटी करके आ रहे हो?
नहीं नहीं सर, मतलब वही ओपीडी था सर, कॉल डे पे है
नौकरी।
जनरल।
गुड।
शर्मा जी को तो पता ही है सर सब कुछ। शर्मा सर आजकल वो हो गए हैं, क्या कहते हैं, द मेन मोटिवेटिंग फैक्टर।
नहीं अच्छा यार, कोई कोई ऐसे ना रहे तो हम जैसे लोग सुस्त पड़े रहते ना।
मतलब मैं पिछले 2 साल में इतनी बार रायपुर जा चुका हूँ जितना मैं पूरी जिंदगी में सोचा भी नहीं होगा उस बारे में,
सही सही
कि
सही।
इतनी बार रायपुर जाने का।
ये
सो,
काफी
सो,
टैक्सिंग भी होता है, मेहनत भी काफी करना पड़ता है ना
बहुत
इसमें।
हाँ,
बहुत इतना इजी नहीं है सर, बहुत डिफिकल्ट है।
सही कह
और
रहे
इतना
हो।
फंडिंग सिक्योर करना इज सच अ पेन, मतलब आई
स्पेशली अब इंस्टीट्यूट्स में ना बहुत दिक्कत होता है यार,
बहुत।
वो फार्मा वाले ना,
या एब्सोल्युटली।
और सपोर्ट कर नहीं पाते हम लोग, मतलब
और
अपने अपने लिमिटेशंस होते हैं।
सर भी खाली थोड़ी ना, मतलब इट इज अ
हम्म
फुल फ्लेजेड रनिंग इंस्टीट्यूट, इंस्टीट्यूट अदर वर्क
हम्म,
आल्सो, बड़ी बात है, नॉट इजी।
ये
We
करते हैं
started
पर
from here only, मतलब अनिल इतने ले रहा है, मैं इसको बता रहा था एक कॉन्फ्रेंस करके 3-4 साल तुम्हारा दिमाग ठंडा हो जाता है कि अब मैंने कुछ नहीं करना।
जी जी।
हमने न्यूरोवैस्को ने की थी 2009 में, उसके बाद हमने की 2016 में, मतलब 7 साल हमने एटलीस्ट 4-5 साल हमने सोचा नहीं, फिर सोचा चलो एक और करते हैं, देन वी थॉट इन 14-15
बट सर
एंड
इंस्टीट्यूट में पॉसिबल भी होता है एक्चुअली। हमारे यहाँ क्या हुआ था कि कोविड आ गया था, तो 2 साल कोई कॉन्फ्रेंस नहीं हुई, फिर निमहांस ने एक ही साल में 4 कॉन्फ्रेंस कर डाली।
हाँ 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 करेक्ट,
तो
आई
तब
रिमेम्बर
वो
दैट
क्योंकि
ईयर,
बट इंस्टीट्यूट था, वी हैड दैट मैन पावर, तो हमने
वी
कर
कुड
डाला
डू।
एक साथ।
हाँ।
बट अदरवाइज बहुत डिफिकल्ट है, आई डोंट नो
नहीं
अनिल।
सर देखो, अभी जैसे कि रिसेंटली हम लोगों ने स्कल बेस कॉन कराया था
हम्म,
एसजीपीजीआई में, तो
हम्म।
मी एंड डॉक्टर अरुण वेर देयर, एंड इतना ज्यादा इन्वॉल्वमेंट होता है ना, आई थिंक आई एग्री विद सर कि आप ना उसके बाद बर्नआउट होता है, आपको लगता है कि यार मेरा जूस निकल चुका है, आपका
हाँ फिर
दोबारा
तुम्हारा दिल नहीं करता, बस हो गया।
दोबारा जोश भरने के लिए थोड़ा टाइम चाहिए होगा, मतलब कि 2-3 साल ब्रेक ले लो। और क्या है ना हर्ष, एक बार तूने कोई नेशनल लेवल का कर दिया ना, उसके बाद तू यू वांट टू डू गो फॉर हायर लेवल, कि और बड़ा मीटिंग किया जाए, मतलब
सर सब आपके जैसे
ये
बड़े
तो
लोग नहीं होते सर, हम छोटे
नहीं
लोग
नहीं, फिर आपको उस हिसाब से प्रिपरेशन भी चाहिए ना कि ना, बट आई एग्री कि इंस्टीट्यूट में बहुत सारे लोग हैं ना, मान लो ऑर्गेनाइजिंग सेक्रेटरी कुड बी समबडी एल्स,
या
तो वो कर लेगा, वो ये सब है।
हाँ,
बट अकेला इंसान मुश्किल होता है, मतलब हेड्स ऑफ टू अनिल, कैसे कर लेता वो।
आई रियली डोंट नो।
हम्म।
हाँ, वो सबका सपोर्ट रहता है, ऐसा नहीं है।
नहीं फिर
फिर
भी
भी
मतलब
एक चार्ज लेने के लिए ना, हर बंदे को के बस का रोग नहीं है कि मैं करूंगा। हाँ सपोर्ट तो मांगे तो मिलेगी, बट आगे चलने वाला कोई चाहिए ना, वो बड़ा मुश्किल
क्योंकि द
डेफिनेटली।
बक बक स्टॉप्स एट यू ना सर,
है।
सबसे
या
बड़ी बात है। कुछ भी होगा तो दे विल से कि अनिल सर डिड द बेस्ट और डिड
हाँ,
द वर्स्ट, जो भी है व्हाटएवर हैपेंस।
या
ये है।
मैं तो कह रहा हूँ कॉन्फ्रेंस छोड़ो, ये वेबिनार करने के लिए भी एक पुश कोई दे तो करता है, नहीं तो सारे बैठे रहेंगे। हाँ हम भी सोचेंगे कोई नहीं बुलाएगा, नहीं तो आ जाएंगे, नहीं तो बैठेंगे हम, यू नो, गेटिंग दैट थिंग फ्रॉम इनसाइड टू गो एंड डू इट, डू समथिंग, इट्स आल्सो अ चैलेंज।
हाँ, this idea was good, sir, actually, for webinar ना। This idea was good, and like selecting topics, एक specific topic लेके फिर उस पर डिस्कस करना।
एक ही चीज है सर, वीकडेज में पता नहीं कितने लोग ज्वाइन करेंगे, वही एक थोड़ा फैक्टर रहेगा।
नहीं मतलब लोग करते हैं, नहीं लास्ट अभी तो कई कई आई थिंक पिछले 2 मंथ से अपन थर्सडे को ही रख रहे
जी
हम्म।
सर।
हैं। नाउ वी हैव प्लान लाइक वील कीप ऑन एवरी फर्स्ट थर्सडे ऑफ द मंथ।
हम्म।
टाइम इज आल्सो सेम 7 to 8 PM।
वो भी ठीक है। एक्चुअली
क्योंकि
वीकेंड
सैटरडे
पे
संडे को तो हाँ इट बिकम्स टू
दिल
मच।
भी नहीं करता किसी का यार, कहीं
या
कोई घूमने जा रहा है, कुछ जा रहा है फंक्शन। वीकडे
एब्सोल्युटली।
पे मोर लाइकली दैट यू आर, यू नो, इन टाउन एंड यू आर वर्किंग, सो 1 hour एक्स्ट्रा यू कैन स्पेयर।
नहीं फिर इससे सर एक वो भी एक वो बन जाता है कि लाइक एवरी थर्सडे देयर विल बी ए वेबिनार, तो सबके माइंड में एक रहता है।
हाँ।
एक
या
तो वो भी है, दिस वाज सजेस्टेड बाय डॉक्टर मानस एक अपन
ओके।
एक फिक्स टाइम पे उसको रखें।
हम्म।
बाकी देखो क्या ना, ओनली इंटरेस्टेड पीपल विल ओनली ज्वाइन, ये भी सच्चाई है। इतना ज्यादा एक्सप्लोजन है मटेरियल के अभी
आई
ऑनलाइन,
नो।
तुम कितने लोगों को पकड़ोगे, माने अपनी अपनी इंस्टीट्यूट के स्टूडेंट ज्वाइन कर ले, वो भी बहुत है, वो भी मतलब
हाँ
मुश्किल।
सही।
वो ही नहीं करते हैं।
वो भी नहीं आते।
वो
मैं
भी
कल
आगे
जाके
नहीं
वो
पूछूंगा ना,
आते।
कल पूछूंगा कितने लोग ज्वाइन किए थे, सब मुंह लटका के खड़े हो जाएंगे,
वो
मुझे पता है
यही बोलेंगे, अरे सर
काम में थे,
कुंतल नहीं
ओटी
नहीं
था।
सर, कुंतल सर क्या ही बता देंगे, वो तो रोज ही मिलता हूँ, या हर्ष क्या बता देगा, वो रोज ही मिलता हूँ मैं उनको, क्या ही बता
देखिए
देंगे। मतलब यही अगर कोई मतलब किसी को बुला लोगे बाहर से, अरे ग्रेट है मैन हैज कम, आई विल कम एंड अटेंड।
वो
घर
तो
की
है
मुर्गी
यार,
दाल बराबर वाला
वो
सिचुएशन।
तो है यार।
नहीं, पर कुछ ना कुछ सीखने को मिलता है, मतलब
सर
ये
आप प्रिपेयर करने में कितना सीखने को मिलता है। वन ऑफ द बिगेस्ट रीजंस आई, मेरे को लगता है कि यू शुड डू दीज थिंग्स, कि मैं पढ़ता हूँ 4 चीजें, मुझे 4 चीजें नहीं पता लगती हैं कि अरे ये अच्छा, ये तो सोचा ही नहीं था कभी ऐसा भी हो सकता है।
सही कह रहे हो। फॉर दैट रीजन मैं अपने रेजिडेंट्स को ये
एब्सोल्युटली।
बोलता हूँ कि केस रिपोर्ट वगैरह क्यों लिखना चाहिए, मान लो उसे कोई इम्पैक्ट नहीं, कुछ नहीं, अरे भाई उस बहाने थोड़ा पढ़ लेगा तू। हम ऐसे पढ़ते थे, कहाँ नहीं तो कोई पढ़ता है रेसिडेंसी में, बताओ।
अब नहीं सर, हाँ सर, अब तो 100 के बाद तो न्यूरो सर्जरी उठ रही है बहुत, लाइक
बुरा हाल है।
गोइंग डाउन नाउ वेरी बैडली, सैडली और नॉट सो सैडली, बट दिस इज द हार्श ट्रूथ। सिर्फ INI CET वाला थोड़ा फिर भी लाइक थोड़ा अभी भी
वो भी
है
मेरे
क्या।
को डाउट है कि ज्यादा दिन होगा कि नहीं, द वे थिंग्स आर गोइंग ना।
पिछले साल तो बहुत अच्छा था सर, रैंक 3 आया था ऑल इंडिया हमारे यहाँ।
अच्छा।
अभी तो अच्छा है। अभी मतलब मेरे तो अभी 2 रेजिडेंट ज्वाइन किए हैं अभी रिसेंटली। एक तो आज ही
हम्म।
किया है, कल एक कल किया था।
नहीं अभी टचवुड एटलीस्ट INI में ठीक चल रहा है, अभी बाकी मुझे पता नहीं क्या चलेगा बाहर।
सही कह
बट
रहे
मैं तो फिर भी सोचता हूँ यार, ये न्यूरो सर्जरी जो है, ये वो मैकेनिक ट्रेनिंग जैसा है, मतलब इट्स बिटवीन यू नो, उस्ताद शागिर्द वाली उस तरह की टीचिंग है।
हो।
या
द टीचर शुड ऑल्सो हैव सम से इन सिलेक्टिंग कैंडिडेट। मतलब हमारे पास वी हैव अ 6 ईयर कोर्स, नो, 2 कैंडिडेट आते हैं हर साल। वो
ओके।
अपनी मर्जी से हमें सिलेक्ट करके तो आ रहे हैं, पर हमारे पास जीरो से है सिलेक्ट करने की। नीट लिख के आ गए, उसकी मर्जी है जो आ गया। अब हमें
हम्म।
वो घोड़ा है या गधा है या उसको हमें इंसान बनाना, वो तो मुश्किल है ना। छोड़, जैसे हमारे टाइम में जब हमने एमसीएच एंट्रेंस दिया था तो हमारे पास वो भी था, प्रैक्टिकल भी था। मुझे याद है थ्योरी भी थी और प्रैक्टिकल भी था, और उसमें मार्क्स वो ऐड करके, और
फाइनल
बॉस
आता था।
बॉस डिसाइड करता था बेसिकली किसको लेना है। अगर उसको नहीं बंदा पसंद या कुछ है, वो उसको कम प्रैक्टिकल में देके और निकाल देगा।
जी जी।
बट नाउ इट्स टोटली बेस्ड ऑन दैट गाय, द स्टूडेंट which I mean who wants to come, and zero input from the teacher. But next 6 years I am supposed to do everything, whereas I had no choice in deciding whom to take.
नहीं
That's a
सर, आई
bit.
आई एग्री विद यू, क्योंकि मुझे लगता है ना कि न्यूरो सर्जरी बाकी फील्ड से अलग है, एकदम ही
Yeah.
अलग है। न्यूरो सर्जरी और कार्डियक सर्जरी जो है, हम लोग एज ए जनरल सर्जन कहाँ ही मतलब इतना हवा लगता था।
हाँ
आई थिंक इन दोनों को तो कम से कम ऐसा हो कि
हाँ
डेडिकेटेड लोग ही आए, बाद में भाग जाते,
वही।
बर्नआउट होता है, काम नहीं कर
हाँ,
पाते, ऐसा होता है।
इस लाइक अगर किसी को म्यूजिक ट्रेनिंग देनी है, उस किसी को गिटार सिखानी, हारमोनियम सिखाना है, तो मेरी मर्जी, मैं कोई भी उस्ताद के पास चले जाऊं। पर उस्ताद की कोई मर्जी नहीं है,
उस
मुझे गाना
उसका भी
सीखना
क्यों
है।
सिखाएगा।
हाँ, लता मंगेशकर बैठी हुई है और कोई ऐसे ही बैठा हो, मैं बोलूँ नहीं मैं लता मंगेशकर के पास जाऊंगा। पर उसकी कोई से नहीं है कि मैं सीख भी सकता हूँ गाना कि नहीं।
सही
शी
सही
कैन नॉट
सही।
डिसाइड हाउ इज इट लाइक
आई एग्री कंप्लीटली। तो अनिल शुरू करेगा, 7 बज गए जरा।
Yeah, now it's 6:59. Yeah, we can start now.
मैं एक बार
मे बी
शेयर करके चेक कर लेता हूँ सर।
Good evening. Can you hear me?
Sir,
जस्ट
yes, sir. Good
हेलो
evening,
सर,
sir.
गुड
Good
इवनिंग।
evening, sir.
Sorry, I'm still traveling back to home, so I'm in car.
Yeah, good
गुड
good
इवनिंग
evening,
A
sir.
सर, हाउ आर यू?
lot of all good, all good.
सर
A lot of traffic. I hope you don't mind.
आई थिंक अनिल, अब मे वी कैन वेट फॉर 1 or 2 minutes, मे बी क्रॉस 7 एंड देन स्टार्ट। दो
या
मिनट
श्योर
बाद
सर,
कोई 2 मिनट
व्हाटएवर यू
वेट
से।
कर लो। हाँ,
या सॉरी।
सर ये वीडियो इज प्लेइंग ना सर?
या
Yeah, it's playing.
गुड।
Yeah, so very good evening. I would like to welcome all the eminent speakers and panelists for the webinar and all the participants. And today we'll be discussing about distal anterior cerebral artery aneurysm. DACA aneurysm are very peculiar, as we all know, due to variety of certain features like their distal peripheral location, broad-based aneurysm, unfavorable dome to neck ratio, and association with multiple aneurysm and with traumatic and mycotic association. So all these factors, but still in this today's endovascular era, these aneurysm are mostly treated by microsurgery. So we have eminent speakers today: Dr. Deora from NMS Bangalore, Dr. Kuntal Kanti from SGPGI Lucknow, and Dr. Tushit has not joined yet. I think I'll check. He's from Ahmedabad. And we have eminent panelist who needs no introduction: Dr. P. Sarath Chandra, Dr. Jaspreet Singh, and Dr. Ashok Gandhi. Dr. Singh has not joined yet. So we can start with Dr. Hasdevda will be speaking about basics of surgery and about basics of anatomy.
Good evening, everyone. I hope everything is visible and you can hear me.
Yes,
So,
yes.
my topic for today is the anatomy and basic tactics for surgical clipping of distal AC aneurysms. Before I start, I have no financial disclosures. The operated cases are my own, and some of the anatomical images might be borrowed. So, in this era that we live in our generation, operating aneurysms is like a ballet of sorts. And unless you have a good training, the best tend to crumble under pressure. And it is a rare privilege in our generation to operate aneurysms, to clip aneurysms. And hence, it should be treated like one. Coming to the very basics of
In this video, we're going to
aneurysm
talk about
surgery,
the
that is, the distal AC aneurysms usually are defined as the aneurysms which arise distal to the anterior communicating artery. After the A1 divides, after the A1 joins each other using the ACOM, it gives rise to the A2 branch. The A2 branch will give rise to what is known as the recurrent artery of Hubner, or that is the first artery that comes out of it and doubles back towards the A1. It will then give rise to the medial orbitofrontal artery, the frontopolar artery, and then the same will continue along the corpus callosum and be divided as A3, A4, and A5. A3 is defined as from the lower part of the genu to the upper part of the genu, and from the upper part of the genu to the coronal suture is the A4, and distal to that is the A5, which then terminates into the parietal branches, inferior and superior parietal branches. One of the main branches of the A3 is the calloso-marginal artery, which will arise mostly from the A3 part, which will give rise to at least one of the cortical branches, that is the anteromedial, infromedial, and posteromedial frontal branches, and or the paracentral branch. These are again all the cortical branches. These will obviously have certain more callosal branches, the short, recurrent, and callosal arteries which arise from this. Revising this once again, ACOM gives rise to A2, gives rise to A3, pre-coronal, post-coronal, A4, and A5, which will terminate into the choroid plexus of the third ventricle. Now, it is often a misconception that these two A2s or the distal AC arteries lie side by side. This is not the case usually. The two arteries usually lie anterior-posterior to each other, and this will be very important when we dissect these aneurysms, because most of the arteries will be anterior-posterior to each other. Another important variation that needs to be understood is the pre-callosal artery. It is different from the pericallosal artery. The pre-callosal artery, which will arise from the anterior communicating branch, this will usually, if it is large enough, it will give rise to branches which will supply the diencephalon on the corpus callosum, and these needs to be preserved while dissecting the ACOM complex and the distal A2 branches, so as to not to damage the same and cause infarcts. Another important factor or anatomical aspect which will play a part in this is the forks, which usually needs to be divided approaching these aneurysms via the interhemispheric approach. The forks usually has a good distance between it and the A2 anteriorly. However, the same will not be there posteriorly, as the A2, A3s will or the A4, A5s will hug the forks on the posterior side. Hence, dividing the forks anteriorly, you will get enough distance to the A2. However, the calloso-marginal artery may be nearby the same. Now, the most important artery, in my opinion, in these these aneurysms is the calloso-marginal artery, because it is often very variable. The first variation can be that the calloso-marginal artery arises distal to the genu, and hence the aneurysm arising at its top needs dissection of both the calloso-marginal arteries and the pericallosal artery, and then only the same can be clipped. An important thing that needs to be understood is that the aneurysm may form a blind spot to which may obviate the need or the dissection of the proximal control, which may be achieved later in these cases. Another variation which may arise in this same is the calloso-marginal artery may arise just after the anterior communicating artery and go much more anterior than usual, be very near the surface, and the aneurysm may arise at its surface. Now, this is very favorable for the neurosurgeon because it needs dissection of only one artery proximally and one artery distally, and the dissection interhemispherically is very minimal. Illustrating by the case is a case of an distal AC aneurysm which was arising from the calloso-marginal branch, as you can see here, and it was quite distal and very superficially seen in these cases, and had presented with a subcortical or a subarachnoid hemorrhage. Now, an important adjunct that may be used in these cases is the navigation or CT angio navigation that can be used. This will help us in limiting our interhemispheric dissection, as can be seen in this case. A very minimal interhemispheric dissection will lead to seeing the branches. Note is made of the cotton which is put anteriorly and posteriorly, which act as a natural separator of this interhemispheric fissure and prevents any venous ooze that is seen here. You can see that the aneurysm is already seen here without hardly any dissection being done here. This is the distal calloso-marginal artery, and then the proximal calloso-marginal artery is then dissected. I usually like to push a ballpoint where my clips are supposed to come. This is the ballpoint being pushed, and it is seen distally here now. You can see the ballpoint coming here distally. I know that the path of the clip is now ready. I have dissected the proximal control just in case. However, since the aneurysm is quite small, we can directly go ahead with clipping of this aneurysm using a standard right angle clip. Here the clip has to be placed very carefully so as to not occlude these small distal calloso-marginal artery. Once this clip has been placed, a minimal dissection can lead to complete occlusion of these cases. Patient was then uneventfully discharged the very next day. Post-operative check angio obviously showed no residual aneurysm being present and with distal filling of all the vessels. Now, another variation that may arise in these cases is that the callosum-marginal artery may divide quite superficial or quite superiorly in these cases. The previous was quite low. Usual division is just distal to the aneurysm genu, and one division may be quite superior. Now, in this, again, it is very favorable to the neurosurgeon because the callosum-marginal artery can be seen distally, the pericallosal can then be divided, and the aneurysm is superficial and facing towards you. However, the main problem in these aneurysms that comes is that the type of clipping or the clipology that has to be applied in these cases is very important, because you need to preserve both the arteries and not just one. A case in point is this distal AC aneurysm arising from the pericallosal callosum-marginal junction, which had a very shaggy margin and irregular configuration, as can be seen in this visually reconstructed image, and hence needed a lot of manipulation while clipping the same. This can be understood while seeing a case. This case was, again, all these cases were approached using an interhemispheric approach. The proximal control was first sought, and the proximal A2 was then dissected. Once you have got the proximal control, the guide for the finding the aneurysm in these cases is to find the clot or the bleed point here. This is the clot or the bleed point that was seen. You can see that the aneurysm is starting to show itself with the atherosclerotic plaque here. Once the clot has been removed, you can get proximal control and start dissecting the aneurysm further. As I told previously, the aneurysm margins were quite shaggy. One of the distal branches is quite well seen here. Now, initially I had tried to clip the same using a right angled clip. But as soon as I clipped here, you can see that one of the branches was occluded by this clip because the curve of the clip was causing occlusion of this. Now, what I try to do after this is that I try to push it proximally. However, then there was a remnant of the aneurysm present. Then I removed the same and used a straight clip distal to clip the distal half of the aneurysm. This ensured that the two distal branches will still remain patent. Once this was done, we moved our attention towards the proximal part of the aneurysm. However, I tried to anti-tube the thing, that is by clipping multiple clips, however picket fence it, but the aneurysm plaque or the atherosclerotic plaque prevented me from doing the same. As you can see here, it kept slipping. Hence, we then moved on to another configuration, that was a right angled clip to make a U-shaped clip configuration, which also occluded the aneurysm completely and prevented any distal prevented any occlusion of the distal branches, as can be seen here. Post of ICG showed that both the vessels were filling quite well. The aneurysm was completely dark. Proximal and distal flow was maintained. This was also seen in the post-operative angio that was done in this case. As you can see that the configuration was a U-shaped configuration with the distal flow being maintained in these cases. This was also seen in the post-operative images, which showed that the distal flow had been maintained. Another variation which is the most difficult in these cases is that the callosum-marginal artery arises below the genu of the corpus callosum. Here the division is so low that the aneurysm may hide the proximal control completely, or one of the branches may actually hide the aneurysm and prevent its dissection, and proximal control may not be achieved in these cases and may need to be directly clipped, and hence it is the worst case scenario for a neurosurgeon in these cases. Now, does anterior communicating artery configuration matter to a neurosurgeon while clipping a DACA aneurysm? In my opinion, it does. Usual configuration is that the two A1, A2s are co-dominant and the ACOM supplies both the sides equally. This is the usual configuration seen in the ACOM aneurysm, that one of the A1 is dominant and the ACOM is seen projecting towards that side. Another variation is where there is a double ACOM aneurysm and may be injured during the proximal dissection of the A2, and this is one thing that needs to be carefully studied. Another variation is that the recurrent artery of humor might be big enough to be confused with the callosum-marginal artery, and hence you might dissect the wrong artery and injure it. Another variation is the multi-channeled ACOM, with one of the recurrent artery of humors being much bigger than the other. Third variation is that the A1 itself may divide or duplicate itself and hence get confused with the callosum-marginal artery or the pericallosal artery while dissecting the same. Triplication of the A2 is also another common, another variation that may arise. And this artery, if big enough, is called, again, as I told, precallosal artery, which may supply the diencephalon and the corpus callosum. Another variation is that the A1 might be big enough that it moves anteriorly and covers the tuberculum sella, and hence the dissection may need to be carried on much more anteriorly to achieve proximal control in these cases. Now, a very important artery that needs to be discussed in DACA aneurysms and needs to be understood is the recurrent artery of humor, which will usually arise from the A2 just distal to the ACOM. It is one of the unique arteries which will double back on its predecessor artery and will supply the anterior perforating substance in most cases and the anterior limb of the internal capsule. It is usually single in 28% of the hemispheres, 2 in 48, and 3 in 24% of the hemispheres. Its injury, as we all know, will cause faciobrachial weakness plus minus aphasia if it is on the left side. Apart from this recurrent artery of humor, there are other basal perforators, 8 basal perforators. Injury to any of these may cause what is called as the flat effect or abulia being developed in these cases, which leads to emotional disturbances and fear and anxiety. It is a common misconception that the A2 itself will not have any perforating branches, but A2 itself has some perforating branches to the internal frontal artery, anterior perforating substance, optic chiasm, and the suprachiasmatic area, and these need to be preserved while dissecting this artery. Another important relationship which is surgically important is the relationship between pericallosal and callosomarginal in terms of their size and the number of branches that they give. This is an inversely proportional relationship. That is, if the callosomarginal artery is big, the pericallosal artery will automatically become small, and vice versa, and the number of branches given by each of these will be completely different or dependent on the same. Usually there are 8 cortical and 4 callosal branches which arise from this. The cortical branches, as I told, are the orbitofrontal, frontopolar, anterior, middle, and posterior interfrontal, paracentral, and superior and inferior parietal. There are various variations. One may be the absence of ACOM, the A1 directly continuing as A2. Another variation is that the callosomarginal may give the anterior branches, that is the frontopolar and the anterior inferior frontal. Another variation is that the callosomarginal may give all the internal frontal, anterior, middle, and posterior interfrontal. Third variation is the callosomarginal becomes the dominant one, which supplies the 4 cortical branches, with the pericallosal only supplying the parietal branches. So usually callosomarginal will give at least one internal frontal artery, usually the middle one, or the paracentral artery, and all the other branches are given by the pericallosal artery. Now, relative supply of these two also varies. That is, the callosomarginal artery will usually give the superior medial frontal part of the frontal lobe, that is, which will be wider anteriorly and become thinner as we go posteriorly, and everything else will usually be supplied by the pericallosal artery. This is an important concept that needs to be understood, that the pericallosal artery may actually supply bilaterally. That is, one pericallosal may supply both the hemispheres, some part of it at least, and this has an implication in terms of aneurysms also. As Anil sir told previously, these arteries may have mirror aneurysms or kissing aneurysms. This was one of these cases where there were 2 aneurysms. One was arising from the left ICA and one was from the right ICA. The left ICA was the dominant one, which had ruptured and caused intraventricular hemorrhage, which was arising at the branch point. As you can see, the left ICA is the left A2 is the dominant one, which usually supplies the A2 one aneurysm and the other aneurysm also. And the right A2 is the lesser dominant one, which supplies only the one of the aneurysms here. One important difference in the distal AC aneurysm clipping is that it does not matter, or the sequence of clipping does not depend on which aneurysm has ruptured. The sequence of clipping depends on which aneurysm is seen first, because one of the aneurysms has to be clipped so as to allow for dissection of the other aneurysm. Again, placing a cotton anterior and posterior allows for separation of the interhemispheric fissure. This is the right A2 proximal control, right distal callosomarginal artery, right distal AC aneurysm which has not ruptured. Usually, common sense would dictate to clip the ruptured aneurysm first, but as I will show you later, the clipping of unruptured aneurysm was more important initially in this case. Once you got the proximal clip, you use a permanent clip to clip across the aneurysm. Once this has been achieved, now you can see that we can manipulate this aneurysm much more freely once we have secured it, to release the adhesions between the right A2 and the left A2. Once the adhesions have been released, the proximal control becomes much more easier in these cases. Sharp dissection is done for the aneurysm. You can see that the left A2 is much bigger than the right A2. The 2 divisions are seen, and now you can see that the aneurysm is showing itself here. As you will see here, the neck of the aneurysm can only be dissected if you have secured this aneurysm. This much manipulation is only possible if you have secured this aneurysm. Once you've secured the same, the neck of the aneurysm is dissected. This is the one side of the neck, and this is the other side of the neck. Yeah, this is the other side of the neck. You have to pass the dissector completely to allow the blades to pass through. A simple straight 7 mm clip was then used. As I told previously, the A2 has perforators, not the callosomarginal or the pericallosal, and hence the temporary or the permanent clip rather can be passed in completely and then clipped without any fear posterior of any artery being there posteriorly. This is the ICA. The proximal filling, distal branches are filling, the aneurysm is completely black and not filling itself. So I come back again, the post-operative angio obviously showed no residual aneurysm with distal filling of both the A2s. Patient was uneventfully discharged. Repeating myself again, precallosal artery might be big, supply the diencephalon and corpus callosum needs to be preserved. Apart from the variations, there are certain anomalies which need to be understood, that there might be a triplication of the A2s. Bihemispheric branches are different from azygous ACA. Bihemispheric branches when there are two pericallosal and supply both the hemispheres, and hence a dissection or separation between them might not be possible. Azygous ACA itself has a different classification. Type 1 is the usual one which we imagine would be the azygous ACA, that is the distal A2 is a single pericallosal artery. Type 2 is a small median azygous ACA which ultimately divides into pericallosal. The third one is two separate A2 segments, out of which one becomes very short and the opposite one actually has bihemispheric branches. Type 4 is one which has only callosomarginal and the other A2 gives both the pericallosal rather than one azygous. And type 5 is the triplication of the azygous ACA which we know. Now this is an important and easy way to remember that it is all fine while doing cadaveric dissections and understanding anatomy. But the real knowledge can only be understood when you actually operate these cases. As Bruce Lee once said, practicing martial arts on boards is fine, but boards actually don't hit back. Similarly, cadavers don't bleed. Unless and until you actually operate these cases, this operative anatomy may not be very clear to you. Last but not the least, it is important to know the veins in these cases. That is, the anterior frontal and the middle frontal veins might be there, and these can be sacrificed if necessary. However, in most of these cases, you will find that there is always a window which is there, and that window can then be re-explored or explored to separate the pericallosal branches. Now, take-home points are that the study of pre-operative angiogram is necessary and very important. And you should know the branch points of the pericallosal and the carosomarginal arteries. Proximal control may not be always possible in these cases, but has to be sought after and then only discarded. Tentative clipping and re-clipping may be necessary to achieve an ideal configuration of clips. And venous anatomy is very important, and any damage to the veins is purely unnecessary in these cases. As my mentor once said, that the best surgeon is one who makes difficult surgeries look easy. Because if you see a swan swimming on the lake itself is very calm, but the legs are vibrating quite vigorously below. So the trifles that make perfection is studying the anatomy, and the perfection will then be your surgery. Thank you so much.
Very nice demonstration, Harsh. You have covered all majority of the facets of the DACA aneurysm surgery very well. And what you said in last slide, I also would like to comment on that. Like there is no harm in planning a little big craniotomy, parasagittal craniotomy, particularly keeping in mind the preoperative anatomy that can be studied in the MRI in relation to venous anatomy. There is no harm in planning a little bigger craniotomy. So there is one question. Would you like to cut open aneurysm after clipping it to confirm complete occlusion, especially when both progs are not approximated well or in atherosclerotic aneurysm?
Yeah, so this is debatable. Whoever has asked, because cutting open the aneurysm is an important thing. If you have ICG, may not be necessary, and you have to understand the fact that while cutting open, you might actually go towards the neck and cause more problems than good. So I personally would like to remain safe and use ICG, which is available at most of the centers right now, and that should be good enough in most of these cases.
Can I say something?
Sir, yes, sir.
Yes,
So
sir,
yes, very well presented. So yes, many people, they want to cut open the aneurysms, but we also have to remember the fact that the fundus of the aneurysm can be attached to the adjacent vessels.
Yes.
So in that case, over
Absolutely.
dissection sometimes could be disastrous.
Yeah.
So the idea is you have to expose the neck as well as you can, ensure there are no other vessels there, clip the neck, and then it's done. It's not a tumor. So one should not kind of dissect out everything, demonstrate this perforator, that perforator, show that, and then clip. That could again lead to problems. One thing about DACA aneurysms is whenever we do a craniotomy, we find that we are always have the risk of exposing the fundus first.
Yeah.
Because the fundus is kind of pointing out to you. So when you dissect, unless you really have to go to the base and start there, but generally when we do a parasagittal craniotomy, not going to the base, generally you come across the fundus first. This could be a bit difficult for the beginners, because for beginners, exposing fundus first. So in those cases, they may try to go a more basal craniotomy. But personally, I don't like doing too much of a basal craniotomy because the sinuses may be exposed. So parasagittal is okay. And even if you expose fundus first, it's not such a disastrous.
Yeah.
And there is also a higher risk of rupture of DACA aneurysms. At least that is what I found.
Yes, sir.
But it's not something unnerving.
Yes.
One has to tackle how to take care of ruptured aneurysms. If one does that, even if it ruptures, it's not such a big thing.
Yes, sir. One of the things that somebody told me was that one of my seniors told me that the fear of rupture has to be converted to a response to rupture. That fear has to be, changed to a response rather than just fearing that rupture might occur.
Absolutely, very well put. In fact, I find that as the experience of surgeon increases, the rate of rupture also increases. And the incidence of vasospasm comes down.
Yes, sir. Yes. That's true.
So when you have less of experience, you go on putting more duration of mini clips,
Yeah.
temporary clips. So you have your temporary clipping time is higher.
Yeah.
So you have a higher risk of causing neurological deficits and vasospasm, all the complications. But once you have more of experience, your incidence of rupture can actually increase. But your incidence of complications, vasospasm, and rest of the things come down.
Yeah, absolutely. There is one more question. Is bilateral craniotomy needed? Only a single side craniotomy across sinus is enough. Nor cutting of falx is required.
Yeah, that is also true. But usually, like in bilateral aneurysms, so there was no question of that. Usually, in these cases, I don't know. At our center, we usually use a Manman craniotome. Drill may not be always available. Manman has a slight bone loss which happens, and it is very unsightly to have that bone loss right in the middle of your forehead. So if you do a bilateral craniotomy, actually the cosmesis is beautiful. I mean, in most of these cases, and you can actually approximate it quite well. That said, if you are comfortable and the brain is not bulging, please go ahead with a single side craniotomy. Absolutely, by all means, there is no problem.
So I request all the panelists to comment.
Yeah, Harsh, it was a wonderful presentation.
Sure.
Now, 2 or 3 points which I just want to highlight, and one of it which was not put across was, how do we plan a craniotomy? I think it's very important. Rather than just going how to clip, how do we plan a craniotomy? I think the best thing which was written on that was by Professor Sen Gupta. So he had told that you do a unsubtracted angio also. So he had described 2 lines from the dorsum sellae going to the inion and one perpendicular going across from that, which cuts cuts through the aneurysm and then goes to the vault. And that point on the vault where you mark it on the unsubtracted angio, you make a craniotomy on either side of that should be your midpoint of the craniotomy. That is one thing which Professor Sen Gupta had described about DSE aneurysms. I think that is very important, and take an unsubtracted picture, mark those lines and then go, because we have seen people, starting
Getting
with thing
lost.
and not finding an aneurysm.
Yeah.
It doesn't happen in any other aneurysm,
Yeah.
more so with
DACA
DACA. They're not able to find it. Second is this attachment. The peculiar thing about DACA is that attachment either to the cingulate gyrus or to the
Yeah.
corpus callosum or to the lower forks. That is why maybe our rupture rates are higher in DACA as compared to other aneurysms. So we have, and then sometimes we dig into the corpus callosum, cause more neurological damage, trying to search for the aneurysm. In same way, through reduced rupture rate as well as reduced neurological deficit rate, that same fund of Professor Sem Gupta of marking the unsubtracted angio, I think, is helpful. Yeah, third thing, Professor Yasser Gill has, described in his book Microsurgery, which you read. He, for every other aneurysm, he has said go from proximal to distal. And then he says it is acceptable only in DACA that you go distal to proximal. So we all have to remember that we are not doing anything wrong by going distal to proximal. It is accepted fact. Professor Yasser Gill also told that we go distal to proximal to find a DACA aneurysm. And we have all done it and we have been doing it. Then, as Anil had started the thing about, because of peripheral location, broad-based, a bad, unfavorable neck fund. That means the ratio of the fundus to the neck, which is unfavorable, favorable, broad-based. So these things sometimes take our decision away from coiling. Anyway, the coiling guy is going to talk about it, but because like personally we do both clipping as well as coiling, we are dual trained surgeons, and so for DSCA, a lot of times, one, it is a very distal location. You have to sometimes the catheters going, you think, oh, so many tortuousness is there, we will not reach the place properly with the catheter. We'll straight away go for a clipping. It is easier for us, so that takes us towards clipping. Second is because of broad base, we have to do a stent assisted coiling and our costs go up, and also we think, okay, we will go for a straightforward clipping. So that is true. Another thing which I would say is we use a lot of tentative clipping, especially in DACA. Instead of always putting a temporary clip on the parent vessel, and sometimes when we are going distal to proximal, we don't have a parent vessel, to put a proximal clip. So we put a tentative clip. I think that can be highlighted to the beginners a little bit more. Whatever you think is a neck, even if you're not sure, like he did with a ball dissector, if you're not able to do that, still you can put a tentative clip at the place where you feel the neck is there, and then dissect some more with more confidence. You're not going to rupture it because you have some control, and then you adjust that clip. That clipping we call as tentative clipping, and then we make it a permanent clipping. So this is my take on the topic.
One more thing was, sir, nowadays the neuronavigation has become so widely available that most of the times you can actually use the CT angio itself. And it limits the first case that I showed, the hardly like literally 2 centimeters of interhemispheric dissection, and I was on the aneurysm. I know it may not be available everywhere,
agreed.
But wherever it is, like it is a boon.
That is the best thing.
You should not shy away from technology, as I understand. I know we all like to say that I can do everything without anything being available, but I mean technology is your friend at the end of the day, and outcomes of the patient matter rather than beating our egos about it.
Definitely, yes.
Yeah, very very well pointed out. Actually, I feel like DACA aneurysm is the only aneurysm where neuronavigation can help you. This is the only aneurysm. In other aneurysm, it's not applicable. And other thing, like we have variety of approaches for DACA aneurysm. Like we can do parasystal craniotomy, bifrontal craniotomy, and sometimes in more proximally located aneurysm, terminal craniotomy also can be helpful. That aneurysm can be clipped by terminal craniotomy also. So now, any other thing for discussion? So
Hi, Anil.
One
Kuntal
thing is that the right and left confusion. How you going to tackle this right and left confusion? Usually we dissect from the identify the cortical branch of the artery and follow that cortical branch, and that help you in identify that it is from right or left.
So usually, sir, the best idea is to what I usually do is follow the clot basically, or follow the rupture point if you can get that. That will usually
whether it is right and left. Sometimes you have to identify the fundus, but it is, could not identify that it is from the right side or from the left side.
Proximal dissection would help, sir, in these cases.
No, you just follow the cortical branch.
Cortical branch is absolutely
just follow the left-right cortical branch. You will identify.
Yes, sir. Definitely.
And second thing is that bifrontal craniotomy is not good. In that cases, there is sometimes the venous injuries happen, and if you are in the from this hemicraniotomy, the lesser chances of this. So
But
I'm
I
not,
mean, even with the
I'm not
hemicranialotomy, you would
very,
need to go across the sinus to get an interhemispheric window.
mhm.
Ultimately, you will have to go across the sinus, whatever you do.
Across
So,
the sinus, but not in the intramuscular. You open the this dura bilaterally. Or cut.
you may not need to do it bilaterally. Definitely, craniotomy and dural opening are completely different things.
That
I
is
mean, you can do a bifrontal craniotomy, open a single side dura.
on the
Most
side.
of my cases in the intraventricular hemorrhage was M5, so we needed to achieve a bit of decompression. That was one thing. In the lady that we showed, which had a small one, we actually opened only one side. It is absolutely, you're right, sir. There's no problem.
I think all these approaches and various craniotomy and how to plan for craniotomy, all these things we are going to discuss in next lecture.
Yeah, absolutely.
So now I invite Dr. Kuntal Kanti for his next lecture to discuss about variety of approaches for DACA aneurysm. How to plan the craniotomy and approaches. That is the basic.
Yeah. Thank you, Anil. Just before I go to my talk, just wanted to make a brief, short comment on one of the questions in the previous talk regarding whether you want to cut open the aneurysm or not. Am I audible, Anil?
Yes, sir.
Yes, please.
Yeah. So first of all, you have to understand why do you want to cut open the aneurysm, right? There are two specific purposes to open the aneurysm. Number one, you want to verify whether the aneurysm has been completely killed. Number one. Number two, you want to decompress the aneurysm. You want to take out the thrombus, right?
Yeah.
So the first objective can be very well fulfilled by an angio. Fine. I generally do an angio, and after that, if at all I need, I will puncture the aneurysm at small area. This is good enough to decompress the aneurysm. Sometimes the wall of the aneurysm can still bleed despite the fact that the aneurysm has been completely occluded. All you just need to do is do bipolar and it is gone. In the second situation, you have to decompress, for example, in giant aneurysms. So that the situation is different. But in both the situations, first of all, you have to ensure before opening an aneurysm that the aneurysm has been killed completely, right? By the look of it, and if you have intra-op angio. Well, I'll go to my presentation then. Let me know if we can see my screen. Can you?
Yes, it is good.
Yeah. Right. Fine then. Good evening, everyone. I'm Dr. Kuntal. And first of all, I'd like to thank my friend, Dr. Anil, for this opportunity. My greetings to the panelists as well as those who have joined this session. So I'm going to talk about selection of approach and strategies in DACA aneurysm surgery. And most of the thing has already been covered by Dr. Harsh. Let me see how I can throw more light on this. Well, before I start, let's begin with a situation that is pretty common with DACA aneurysms. Here we have a case who's 38-year-old. The patient is grade 2 SH, and you can see there is a dysmorphic aneurysm arising from the commonest point, that is a point where the artery is bending superiorly, and there is an artery that is arising here, that is callosomarginal takeoff. The aneurysm is directed inferiorly. The first problem that we face in such an approach, that is unilateral anterior interhemispheric, is a tense brain. And with a tense brain, if you put a retractor, it is going to just worsen the situation. So we may have to sometimes do temporary CSF drainage like we have done here. So this is the problem number one, tense brain and difficult access. Once this is done, then we have to negotiate the tight interhemispheric fissure. This is unlike the Sylvian fissure, which is quite wide. As you see, there is no CSF here. And as you dissect, what you go on to hit is the cingulate gyrus. Then you realize that you need to go further deeper, and you try to find the midline, and you become subpile in the process. Eventually, with all the struggle, you go in and kind of your nerves come down when you see this shiny white corpus callosum. But importantly, you have ended up exposing the distal vessel. This is against the tenet of aneurysm surgery. You first expose the distal vessel. Now, once you have done this, you go anteriorly, try to find the proximal vessel, which may be difficult considering it is dipping below the corpus callosum. Now, what happens is an aneurysm rupturing before you can have a proximal control. But as said by Dr. Sarath, Chandra, it is not actually very difficult. All you need to do is just control the bleeding with a tentative clip. And you can go to the proximal part of the artery by suctioning some part of the corpus callosum. Then you dissect the distal artery and the proximal artery. And sometimes you may have to use your non-dominant hand as well to secure proximal control. Now, once everything is under control, then you take this opportunity to delineate the aneurysm completely, because these aneurysms are often dysmorphic, and compared to the size of the parent artery, this size of the aneurysm is disproportionately bigger, like a hydrocephalic head. So it is very, very important to spend some time in knowing what you are dealing with. For example, in this patient, we are going to clip the aneurysm, and this clip application is not final. This clipping here is going to be dynamic. Now, with application of this clip, you are able to take out the distally tentatively placed clip. Now it gives you time to go for further dissection. And you have all the time now to reapply the clip in such a way that you occlude the neck as close to the origin as possible. At the same time, preserve the origin of the callosomarginal artery. Here you see that the aneurysm is not completely gone. There is a small bleb which is coming out from the lower end of the clip. In a situation like this, it mandates application of overriding clip, as you see here. So these aneurysms often require innovative strategies as far as clipping is concerned. And things may not go according to the plan, but at the end of the day, we have to finish the job. So experience is very important. It is said that if one is a good aneurysm surgeon and has good experience with exposure of interhemispheric fissure, this aneurysm should not be very difficult. So here's the patient. So this is also true. Despite all difficulties, most of these patients, they will do well. Well, if surgery is so difficult, can endovascular have a better chance of better outcome? My next speaker is going to speak on this, but just I'd like to highlight to you that whatever head-to-head studies have been done, they have clearly shown that immediate angiographic outcomes are clearly better with microneurosurgery. And considering that DACA aneurysms, they have a high rate of re-rupture, I think this immediate occlusion of the aneurysm from the circulation is what makes microsurgery a preferred choice, even in the era of endovascular treatment. Now, what are the surgical issues with DACA aneurysm that require strategizing? I like to divide them into 3 A's, as you see. These are axis related, then the aneurysm related, and lastly, approach related. And as you see, all these 3 are interlinked. Now, what are the issues with axis of the aneurysm? As you see, this is unlike the traditional anterior circle of Willis aneurysms, which give you a lot of space to work with once you have opened the sylvian fissure. Here, you have to work in the tight interhemispheric space. Often, the brain is swollen and there is interdigitations of the frontal lobe, middle part of the frontal lobe. To make matters worse, you will have a bridging vein over it. Although pre-coronal craniotomies tend to avoid the bridging vein on most occasions, but still, you may be unfortunate that you have a vein running right over or right beneath the craniotomy. And if you decide to go basal, you have to manage the frontal sinus, because frontal sinus has 2 clear disadvantages. That is, it can lead to infection, and secondly, it can lead to CSF leak. Once you have gone inside and you are on the aneurysm, the second issue that you have to deal with is the aneurysm management. As in the previous video, you could see that premature rupture can happen in the best of hands. It is mainly because of the approach that we generally take to these aneurysms. The proximal control is often achieved late. This is unlike the traditional aneurysm surgery that you do for other aneurysms in the anterior circle of Willis or even the posterior circulation. And as I've shown, sometimes you may have to be improvising on table as to what is the best clip application that you can do for a given case. And sometimes you may have to spend some time on it. Then the third issue that requires strategizing is the approach. Whether you're going to go from the ipsilateral side of the aneurysm, if you're able to make out which pericallosal is giving rise to the aneurysm, do you go contralateral or do you go bilateral? Personally, we generally believe in going ipsilateral interhemispheric, as I'll show in the subsequent videos. But in certain situations, we may like to go bilateral basal interhemispheric. Then whether you want to go for basal approach or a vertex approach, which is something that I'll discuss later. And is there a role of mini craniotomy even for this complicated aneurysms? Now, there are various approaches in the literature, but what I follow is a very simplified algorithm. As most of the aneurysms are located at just above the turn of the corpus callosum, there is genu of the corpus callosum, unilateral interhemispheric approach is what I generally do. I tend to go from the right side, even if the aneurysm is arising from the left DACA, unless the hematoma is on the left side, and generally it leads to no problems. For aneurysms which are located just beneath the genu, for some patients, I'd like to go bifrontal basal interhemispheric, particularly if the aneurysm is pointing superiorly. But if the aneurysm is pointing inferiorly, then there is no harm in going unilateral interhemispheric. But one has to realize that To attain proximal control in such a case, you'll have to do some part of corpus callosum resection here because you are hitting right on the aneurysm. And the third situation where the aneurysm is located in the subcallosal part close to the intercommunicating artery, T-renal approach with gyrus rectus resection can be a choice as well. In some of the selected situations, we also do keyhole approaches, as I'll show later. So coming to the simplest of scenarios, this patient has one aneurysm in the proximal part of the distal intercerebral artery close to the ACOM area, as you see here. This is in line with the dominant ACA, A1. And as you see, it has led to hemorrhage in the circle of Willis. So if any patient has circle of Willis bleeding, and if you do not get any aneurysm in the circle of Willis, don't just leave it there. Go and search for a DACA aneurysm. So this patient was taken up for a T-renal approach because it was almost similar to ACOM aneurysm. Frontotemporal incision and craniotomy was performed. The Deora was opened, and the Sylvian fissure is opened widely. Now, this is a luxury. You do not get this luxury for the usual type of DACA aneurysms. As you see here, Sylvian fissure opening has to be done meticulously because it is a great boon to a skull base or an aneurysm surgeon. This not only leads to liberation of CSF and relaxation of the brain, it will also lead to separation of the frontal and the temporal lobes, which will allow you to work with minimal retraction at the site of aneurysm. This is very, very important. And one is to go step by step. In this patient, we started with lateral part of the Sylvian fissure, but sometimes you may have to start with the medial part as well. The important thing is sequential and sharp dissection. And ultimately we end on the optic nerve. As we liberate the optic nerves here by cutting the arachnoid, we are freeing the basal part of the frontal lobe. The A1 comes into our picture and we have the proximal control established. Now, this is not the usual situation in typical DACA aneurysms, but here we are fortunate that we are dealing with a slightly easier case. Then we dissect the intrahemispheric fissure. But as you see, this is a distal AC aneurysm. So opening the intrahemispheric fissure is not enough. You have to also do gyrus rectus resection. Here you see that the ACOM is completely free. The edge of the intercerebral artery is seen, the ACOM area. Sharp dissection is always preferred in aneurysms because the tear resulting from this can be controlled better than a tear from blunt dissection. All you have to do next is to apply clip across the neck and isolate the aneurysm completely. And post-operative angio shows a complete obliteration of the aneurysm. Now, this is a simple situation. Let's come to a situation. Can this be done using minimal invasive means? This is a similar patient, as you see, distal intercerebral artery aneurysm close to the ACOM area. In this patient, the aneurysm was anterior superiorly directed, and the patient had grade 1 SH, and there was no hematoma. So in this patient, we went with a supraorbital keyhole approach from the side of the dominant A1, which was making it a fundus first approach. Even then, we were able to clip the aneurysm and completely exclude it. So certain situations, keyhole approach like supraorbital keyhole can be a choice. And the patient did well in the postoperative period. Now let's come to another situation. The aneurysm is located in the subcallosal part of the distal intercerebral artery. As you see that this is the area of the aneurysm. This is the bend of the distal intercerebral artery at the area of the genu. So in relation to the genu, the aneurysm is located below, but it is pointing superiorly. So as I said in the beginning, in a case like this, I generally go basal interhemispheric. So we started with a bifrontal craniotomy, basal bifrontal craniotomy. And Deora was opened on either side of the anterior part of supraparietal sinus, and the supraparietal sinus was ligated anteriorly. Ligation of the sinus at this point is always safe. And this procedure is commonly done for olfactory group meningiomas, and we rarely have any complication. The important thing is to release CSF and release the optic tracts, olfactory tracts here. And the dissection has to be continued posteriorly till you find the optic nerves. And as you can see, you can access the medial part of the Sylvian fissure as well. The same dissection is done on the other side, and the olfactory tract on the other side is also liberated. Now, this gives us opportunity to open the basal part of the interhemispheric fissure. And as you see, we can release a lot of CSF. So the brain can be relaxed tremendously in this approach, unlike the traditional unilateral interhemispheric approach. We can see the pituitary gland And further dissection leads us to the edge of the entry-communicating artery and the distal enterocerebral arteries. We can see that the enterocerebral arteries in distally are asymmetrical. Further dissection of the interhemispheric fissure is necessary to proceed further. As you see, since there is acute subarachnoid hemorrhage, the brain tends to be edematous. And one has to use retraction. The basic idea of retraction is to just hold the brain, not retract in true sense. And the advantage of this approach is you can see the proximal artery and you can keep on dissecting. So we come to the area of the aneurysm. It is important to remain subpial here. We have exposed the aneurysm, and this is usually our strategy, that these aneurysms are modified utilizing coagulation under temporary control, because it is very, very important that you define the aneurysm completely so that clipping can kill the aneurysm. A term that we generally like to use here is we have to kill the aneurysm, it should not come back again. And to be able to do that, you have to take proximal control. Sometimes you have to dissect the aneurysm completely. If needed, do some coagulation, and finally exclude it from the circulation using a suitable clip. Here we use a straight clip to cover the neck of the aneurysm. And aneurysm surgery should never end after just application of the clip. You have to verify whether the clip has gone across, what is the status of the adjoining arteries, and you have to make sure that the enemy is gone forever. It is very, very important to preserve the arteries arising thereof. Fortunately, there are no major perforators at this area, and ICG, in this case, augmented reality image, is very, very essential, not only to document the patency of the arteries, but also the aneurysm. This is the picture at the end, and the patient made an uneventful recovery. Can this also be done using a minimally invasive approach? Personally, I have never done this, but there are reports, including this report from PJ Chandigarh, where they use an incision between two supraorbital notches in the midline, and they go for a craniotomy here, and they have been able to clip such an aneurysm. Coming to the third and the commonest scenario in DACA aneurysm, that is an aneurysm located just above the genu of the corpus callosum. Like Dr. Harsh has shown, I also have a case of double DACA aneurysm, the kissing DACA aneurysm. And as you see, the pointer is, look at the subarachnoid hemorrhage here. The subarachnoid hemorrhage is just above the corpus callosum. So depending on where the hemorrhage is, you have got to search the aneurysm there. And as you can see, there are two aneurysms. One is a smaller one arising from the right distal enterocerebral artery. And we also see there is one more aneurysm, and these two are located at symmetrical location. And this is what is known as mirror aneurysms. In this patient, we took a interhemispheric approach from the right side, as we said in the beginning that we prefer a non-dominant side. Here we see another challenge. The brain is tense, and we can see that there is a bridging vein coursing here. So what you need to do is to release this vein. This is called arachnoid lengthening. This is a very, very, very important step, particularly for the youngsters, that you need to release this vein from the brain by cutting the arachnoid, which tethers it to the brain. This is very, very important because whatever retraction you're going to do subsequently in the deeper part, this vein can get torn if this is not done. And this is a pretty major vein, as you can see. The steps are then the standard ones. You go and dissect. And with all the difficulty, you finally get on the cingulate gyrus. And you have to understand that you need to go deeper. And the shining corpus callosum is what pacifies the mind of a surgeon who is operating on DACA aneurysms. Now here I want to tell you that you can further expand the space in such aneurysms by evacuating the hematoma, partially evacuating the hematoma. Hematoma can be your friend as well, but just make sure that you do not suck out the entire hematoma because it can lead to aneurysm rupture. Here we did partial evacuation of the hematoma. It led to increase in the space. And we now see the two arteries running side by side. And we also see that the aneurysm is embedded in the frontal lobe. So here we utilize a technique which is called the brain cuff dissection technique. You don't go into the aneurysm first. You go in the adjoining brain where the aneurysm is buried inside the brain. And once you do that, it is pretty much easy to retract. And all you have done is you have left some amount of brain stuck to the fundus of the aneurysm at the point where it ruptured. So you can practically handle the aneurysm without any temporary clipping, provided you have left some cuff over the aneurysm. And I generally like to bear the entire anatomy before I go on and clip the aneurysm. Here you can see I'm using sharp dissection to separate the two arteries. And clearly, one aneurysm has ruptured and the other is still intact. Now we can see the proximal artery, the distal artery, and the aneurysm. It is said that in such aneurysms, you got to have everything in our view: the proximal artery, the distal artery, and of course the aneurysm. You've got to spend some time and see the angiographic anatomy here and decide as to what clip configuration can suitably occlude this aneurysm. In this patient, we utilize a right angle clipping. Once this ruptured aneurysm was clipped, the opposite unruptured aneurysm was also taken care of because it was already nicely exposed. And this could be done even without a temporary control. Finally, we laid out some CSF by opening the corpus callosum. Sometimes this step can precede the aneurysm dissection if you think that the brain is tight. And finally, ICG confirmation is done regarding occlusion of the aneurysm completely. And you can see the interhemispheric space and the preserved vein. The postoperative angio shows the aneurysm is completely excluded from the circulation and the distal arterial circulation is maintained. And the patient did well in the post-op follow-up. Can this be done by minimally invasive means? Yes, it can be. I have done a couple of cases. Dr. Roten had described a mini interhemispheric approach, which we have done. We have also done this kind of cases wherein we utilize preoperative image guidance like MR-guided virtual reality, where you track the most anteriorly placed interhemispheric bridging veins and the frontal sinus, and you can make the craniotomy just at a point where the craniotomy is just in front of the bridging vein, and you're able to dissect and clip the aneurysm. Of course, this was done in an unruptured aneurysm case and which was directed laterally. So keyhole approaches, as you know, need to be highly selective as far as case selection is concerned. Role of neuronavigation has already been stressed, although we use it infrequently, but it can allow quick localization, as Dr. Harsh nicely showed. It can lead to avoidance of frontal sinus. It can tailor the craniotomy. And in my mind, these are applicable particularly in distal mycotic aneurysms in A4, A5 segment. For a reasonably experienced neurosurgeon who deals with such cases, the local anatomy, particularly what one of the panelists suggested, that you just have to retrogradely trace the callosomarginal artery, and this will take you right to the aneurysm. So natural navigation is always available to you. So the take-home message is the key to nailing this aneurysm is to understand the 3 A's of DACA aneurysm, which are access, aneurysm, and approach-related issues. And it is very, very important, and it is usually advantageous to tailor your approach based on the aneurysm location and aneurysm direction. And once you have gained some experience with the usual kind of aneurysms, then these aneurysms can be successfully dealt with and the patients can have excellent outcome in the long-term follow-up. Thank you for your patient hearing.
Very nicely presented, Dr. Kuntal, and you have covered all the aspect of how to decide approach for DACA aneurysm. Now there is one question, little confused whether one should clip the rupture one or unruptured one, because both the aneurysm differ in kissing DACA aneurysm.
See, as both of us showed, Dr. Harsh as well as myself, see, it depends on which aneurysm is coming in the way, right? In my case, both the aneurysms were seen side by side. Fine. So it was left to the surgeon as to which one should be clipped. But in Dr. Harsh's case, it was clear that without clipping the aneurysm which was superficially located, you could not go and clip the deeper one. But the dictum always says you should always go and treat the ruptured aneurysm first. Then you go on to clip the unruptured one. The reason is the ruptured aneurysms, they are fragile. And you know, in the process of manipulation, the chances of rupture of a ruptured aneurysm is much higher compared to an aneurysm which has not ruptured yet.
Absolutely.
So if both are simultaneously exposed, it probably doesn't make a lot of difference. Otherwise, any given day, I'll clip the ruptured one first, followed by the unruptured one. Any other comments, please?
Yeah, I would like to invite panelists for their expert comment.
I think Kuntal has given a very beautiful overview of how to do things in DACA. He made me remember Professor Yuharnius Nemi, because the craniotomies you have used are very similar to how he has done. I mean, we have not done anything through the standard frontotemporal craniotomy or the pterional craniotomy transfilial route, but you have done through that. And then the keyhole approach, supraorbital keyhole approach, which was Professor Yuha's favorite for almost everything. I think whenever I see, I just remember him. I mean, it's good to remember teachers who have, passed away and who have given a great contribution to our fraternity. Yeah.
Thank you, sir. Thank you so much.
Yeah, DACA aneurysm is very fascinating actually, and it's very peculiar. As I mentioned earlier in my comment, like this is one aneurysm where giant aneurysm are exceedingly rare, exceedingly rare. I've operated a giant aneurysm in every location except DACA aneurysm. And as I mentioned, like navigation is very helpful in these cases, and variety of approaches are available. Like you can clip proximally located from tenural craniotomy transfilvian route. Bifrontal approach is also available, and parasagittal craniotomy, as usual, that is the most standard approach for these kind of aneurysm. So these and still, like in this endovascular era, these aneurysm are mostly microsurgical approach is most preferred approach for these kind of aneurysm due to variety of factors as we have discussed already. So
Yes,
any other
Anil.
comment?
So, yeah,
Any other comment?
yeah. If there are any other comments?
I just have a question.
Yes, sir.
If, as we know, the DACA aneurysm, the etiology many a time is traumatic. Am I right or wrong?
No, sir.
Many
Most
a
often,
times, it,
most often they
many
are. Yes, sir. Please
yeah.
go ahead. Sorry for interrupting. Please.
So just I just want to know whether if it is a traumatic DACA aneurysm distal, whether you go for clipping or endovascular procedure,
So
or you just
traumatic.
excise it.
Yeah. So traumatic aneurysms are a different entity. Most often they will have, almost always they will have dissection of the artery involved. So it depends where the location is. If it is distally located, then most of the major branches have already come out. And if there is a big hematoma which otherwise necessitates a surgical approach, and if it is discovered right there, then vessel sacrifice is a reasonable choice. Otherwise, all dissecting aneurysms are perhaps better managed with endovascular therapy. And more than the traumatic aneurysms, I feel the mycotic aneurysms are more common in the distal part of the intercerebral artery, particularly A4, A5 areas. And as you know, the management of mycotic aneurysm has really evolved with improvement in antibiotics and the ability to follow up with angiograms. The incidence of surgery for mycotic aneurysm has really gone down. And with advent of endovascular therapy, even those aneurysms are now nicely tackled by our endovascular colleagues. The problem is with these typical aneurysms which are located around the genu of the corpus callosum, which are particularly challenging for us as neurosurgeons. And a variety of approaches are available. And as I've shown, depending on the location and the projection of the aneurysm, you can tailor the approach. But having said that, I must also tell you that there are institutional biases or preferences. For example, in my institute, we'll probably go for unilateral interhemispheric in almost all cases. Only in some selected cases, like I've shown you, that we have gone the other way around. Similarly, in PGI Chandigarh, I think they prefer a basal interhemispheric approach for almost all aneurysms. So at the end of the day, what suits you, what you are comfortable with, and what gives you best results is what you need to stick to. That is what I believe. But there is a scope for tailoring the approaches, as I've shown you.
Yeah, I agree completely. Like traumatic aneurysm, the shear
Thank you.
force that is developed along the falx, that is the causative factor for developing these kind of aneurysm. And still, microsurgical clipping is the best answer for these kind of post-traumatic aneurysm also.
In this post-traumatic aneurysm, most of the aneurysm does not have neck, and they have pseudo walls.
And
So preferably, arteries should be actually block.
But these
Arteries should be block.
aneurysm usually develops either at the A4, A5 junction or beyond at the A5.
Yeah.
Yeah.
Generally,
Anil,
A4 pe generally,
yes,
and
sir.
for parent vessel should be occluded.
That also can be sacrificed. That also
Yes,
can.
Anil, that said, I have operated and published as well. It is published in World Neurosurgery. This kind of fusiform aneurysm of A1 segment. So A1 segment, this is much more proximal on the circle of Willis, and sacrifice is not an option here. So we have been able to clip occlude and still maintain the patency of the artery. So the management strategy would be slightly different if the aneurysm is proximal, vis-a-vis if the aneurysm is distal. Like Sir has just mentioned, vessel sacrifice is one of the real armamentarium in our hand when it is located distally. Similar to pica aneurysms, if they're located distally, the vessel can be sacrificed. Only when it is located proximally and important branches are there, then you need to think about other options, including bypass, if you need to.
Section anastomosis.
Yeah. Yes. Hi, Sanjeev, how are you?
One more point I
I-
would like to answer. These type aneurysm, these DACA aneurysm specifically,
Yeah.
require least brain retraction and like dissection also, as compared to another aneurysm.
Yes, Anil. Yeah.
Mhm.
I think it has both advantages as well as disadvantages. But for those who have done this, they can get away without much problem. And as Dr. Joha Hanesnimi's group has shown, for strange reasons, the patients with DACA aneurysm, their long-term outcome is actually much better than the other aneurysms. Perhaps because of the fact
yes.
they're located away from the circle of Willis. The perforators are not that dangerous over there. So vasospasm related delayed, neurological functional non-improvement is much less. So despite all difficulties that we face as surgeons, we need to understand that if you're able to clip it well, this patient is going to do exceedingly well in the follow-up.
Actually,
really-
DACA aneurysm does not produce this
Vasospasm.
in the
Yeah.
basal cistern. So vasospasm rate is lesser, so better prognosis.
Definitely.
One
So
comment is
yeah.
at our center, we are doing all the DACA aneurysm by coiling actually. Rarely
sir.
do the clipping. So if we not able to negotiate the microcatheter in the DACA aneurysm, only that or rarely sometimes it is broad neck, then we do clipping. Otherwise, we doing most of the cases by coiling.
So
I
there is
just
a
want to
yes, please.
I just want to make two comments. One for dissecting aneurysm. We had a couple of cases in which there was a short segment of dissection, maybe a traumatic one. So we just took aside and made a end-to-end anastomosis that worked. And another one was a long segment. So we took a STA graft and after excision of that segment, we put an anastomosis. So that is also one viable option. And the second point is that sometime which happened with me just last week, there was a DACA aneurysm which was just anterior to genu or lying just a little below the bend of genu. And when I opened from the interhemistic fissure, I was quite low. I saw the aneurysm, but I could not get the proximal control. So I thought of sucking the gyrus that corpus callosum to get the proximal control, but the aneurysm was not dissected properly till that time. And the gyrus rectus somehow I felt if I suck it, the aneurysm is likely to rupture. And anteriorly, the bridging veins were obstructing my approach. So by no means I will able to take the proximal control. So I was stuck there. So I went subfrontal, did a subfrontal dissection and take a proximal control of both A1 in case rupture occurs. Although I did not require a temporary clip there. Then I go for an aneurysm and put a tentative clip first, then dissect it and got the proximal control, then clipped it. So this is one technique when if you are not getting a proximal control.
So, sir, this is a very important point that you have highlighted. To all the people who are asking me or asking everyone that we should do a SOCA approach, this approach, mini craniotomy approach, let me ask you if this happens to you, what sir has just told. What kind of SOCA approach or the mini pterional or mini craniotomy approach is going to help you? This webinar or the idea of presenting this whole series is that this is for a beginner level. I understand Kuntal sir is a very, very accomplished vascular surgeon. He can do this with his left hand probably. But for a person who is actually starting to do these cases, it is always better to have most of the vessels proximal distal in your view or at least accessible to you, and not try to shoot for the stars and kind of get hurt in the process.
Yes.
This
So
is exactly the point. Actually, these things should not be seen as a comparison of one craniotomy from the other or minimal invasive or maximal invasive. This is a step-by process. once you start from a larger craniotomy, not be just then size and go for a minimal invasive one. That should be done. That should be done, and it depends on their personal experience only.
Absolutely.
Absolutely. So
At the
if
end
I
of the
can,
day, once the
yeah,
aneurysm is occluded, the patient is not going to ask you whether a bicoronal incision was taken, a mini incision was taken, a lumbar incision was taken. That doesn't matter at all. Patient has to be cured and go
Yeah,
back home.
that's
That is
absolutely
the
right.
bottom line.
absolutely.
It
So
has to be safe.
yeah,
It has
if I,
to be safe.
yeah, if I may make a final comment here is, for all the youngsters who have joined this, including our residents, you have to remember that DACA aneurysm clipping is a different ballgame compared to traditional aneurysm clipping, right? So for the younger people, it is going to be difficult. So you have to do a lot of traditional aneurysms, open the cistern, have a wide space, dissect the proximal artery, dissect the aneurysm, clip, and then you do the DACA aneurysms. And if you see the literature, the keyhole approaches are mainly for the circle of Willis aneurysms. For DACA aneurysms, it has not become popular for the reasons that Dr. Harsh has mentioned. It is extremely difficult. So what I wanted to say was, once you are sufficiently experienced, and if you choose your case well, like unruptured aneurysm which is favorably positioned for the access through that particular window, then for somebody who is experienced, he may do it. But I would say it will be less than 2 to 5% of all DACA aneurysms that we see in our clinical practice. Having said that, in my own practice, I will probably clip 25 to 30% of this aneurysm using a keyhole approach in the circle of Willis, not the distal intercerebral artery. So it should be clear. Go for the traditional thing. Be be an expert or be well versed with clipping of traditional aneurysms in the circle of Willis. Then you go to the DACA, and when you have sufficiently graduated and you have a case in your hand, the case is very important. Then probably you can do. Otherwise, of course, the primary goal of surgery, that is successful aneurysm clipping, should never be compromised by an approach. I'd like to tell you what my one philosophy. I always go by this dictum that as surgeons, we have two difficulties in any given case, be it tumor, be it aneurysm. One is the pathology, one is the approach. If you think that the pathology is challenging, go for a simple approach, right? You cannot struggle at two levels. So DACA aneurysm is a formidable adversary. So go the traditional way. Only when the DACA aneurysm appears slightly on the weaker side, unruptured, favorably positioned, you can contemplate utilizing a difficult approach, otherwise not. So no two difficulties together. If the pathology is difficult, choose a simpler approach. If the pathology is simple, if you're fairly experienced, maybe you have a chance of using a slightly more difficult thing. Having said that, patient safety should be the first thing in our minds. Thank you.
Yeah, very well pointed out. Now we have another question. Should we do bifrontal craniotomy in every case of unilateral DACA? As a beginner, please enlighten us.
No. So let me answer this. As I told you, most of the aneurysms, right? Most of the aneurysms are located at the junction of A3, A4, right? Probably Harsh mentioned in his talk that 60% of the cases, the origin of callosum marginal is just below the corpus callosum. In 40% cases, it is above the corpus callosum. It is in normal population. But for some strange reason, most often the aneurysm arises in the supracallosal part, right? So in such a situation, which is the most common situation, you can go for unilateral interhemispheric approach from the right side, almost always. There are situations like the aneurysm is located infracallosal, okay? And the aneurysm is pointing superiorly. In that situation, if you come from interhemispheric, it is possible it will become a fundus first approach. An experienced surgeon can still do it. But for somebody who is not that experienced and you have a case in hand like this, then there should be no harm in going basal interhemispheric. That is what I tried to say. Most often, interhemispheric unilateral non-dominant side. Some cases, you can go basal interhemispheric. In the rarest of rare situation, a DACA aneurysm will be same as ACOM aneurysm, like I've shown you. In that situation, terminal is the workhorse for us.
I would just like to add that I would hate to see a surgeon start DACA aneurysm clipping. Go for a fascinating or a glamorous approach. Fuck up, pardon me for using this word, and then stop clipping aneurysms altogether. that would be the worst possible outcome in most of the any surgeon's life. Be safe, start. You become good, you are at surge level, 100% go for the stars. Nobody's stopping you.
Yeah. Issue settled. Go for the normal thing.
Any comments, sir? Jaspreet, sir?
Yeah, I think we had the panelists who were into endovascular. I don't know if there is another next talk for endovascular.
Yes, sir.
Yeah, okay. We'll, I think, put comments after that. That will be better.
Yeah, Dr. Tushit, please start sharing your presentation.
Yeah. Thank you, Anil. Yeah.
Hello, am I audible?
Yeah, yes, please. Yes, please.
So good evening, everyone. Okay, I think so. You can see the presentation now.
Yes, please. Yes,
Yes.
please.
So good evening, everyone. Thank you very much, CVSI, for giving me this opportunity to present. I will be talking on decision making in surgery versus endovascular intervention in DACA aneurysms. So let us start with some philosophy that overall treatment goal for an individual patient is to provide the safest, most efficacious, and the durable treatment with the lowest associated risk. And that has to be always followed for the aneurysm treatment. So my topic is for decision making. For any kind of the decision making, we require some amount of knowledge, some amount of skill, and lots and lots of experience. For clinical practice, and especially in the neurosurgical practice, and for the aneurysm treatment, we have to choose which is the better for the patient. It should be most effective. The most important part is it should be very much safe. And lastly, it should be durable, that whatever we have done, or as my previous speaker has told, we have to kill the aneurysm anyhow. And for that, whatever means we use, either microsurgery, either endovascular, or microsurgery followed by endovascular, or both, that is, I think so, justifiable. So let us start with first a kind of the aneurysm. It is not a DACA aneurysm. For the sake of the starting the presentation, I have put this. It is a basilar artery aneurysm, a lower basilar aneurysm, which is having this kind of configuration. There is one aneurysm, another aneurysm, one fenestration at the distal part, and one more blade-like aneurysm. So you can count as a 3 aneurysm here. In this kind of the case is somewhat difficult. If we draw out a figure, then you can see there is one aneurysm with distal fenestration, one blade-like aneurysm, and on the another wall there is one more aneurysm. In this kind of cases, we can do endovascular approach is relatively more easier. What we do is we put one flow diverter and also coil into that aneurysm. The flow diverter took both the aneurysm, a blister and a somewhat blade-like aneurysm, and another regular secular aneurysm. So either clipping or coiling means it started in 2002 with ISET trial. In India, we get more of a ruptured aneurysms. So we talk more about that. ISET trial was the first one who showed around 2,000 patients that morbidity with clipping is around 30% and coiling is around 24% at the 1 year. And if we follow that coiled group for around 10 years, the survival rate were better with that part. So they coined that coiled group is better. Also, a byproduct of the study was that there is a low epilepsy in that part and better cognitive outcome. Again, BRAT BRAD trial done between 2003 and 2007. 500 ruptured cases were enrolled. Again, they were showing the same data with some problem of crossover bias, and intent to treat analysis was leaning towards a coiling for the same kind of the cases. So in US, it jumped like anything, the coiling cases. And because of that, gradually improvement into the devices we see. Hello.
Yeah, yes, please
Yeah, you
continue.
are
Yes.
audible.
Yeah,
Audible.
yeah,
Okay.
you're audible. Please,
Okay,
please
okay.
carry on.
Basically, my screen is not showing here. That's why I'm saying. So whenever we have to prove everything, we quote some papers. So this is one paper, a 2021 review paper. They have done very good review, and they are showing that clipping is associated with the higher rate of the occlusion of the aneurysm and lower rates of the residual or the recurrent aneurysm. Whereas coiling is associated with lower morbidity and mortality and better post-operative care. It is for all of the anterior circulation aneurysm. Then comes 2024 paper, a meta-analysis of the anterior circulation ruptured aneurysms, again showing the same things with no statistically significant differences between the two groups regarding the poor outcome, long-term mortality, rebleeding or vasospasm and hydrocephalus. But still, a systemic review illustrates that the neurosurgical clipping may be superior to endovascular coiling for ruptured anterior circulation aneurysms. When we narrow down more to that part, for the anterior cerebral artery aneurysms or endovascular treatment, a paper from 2015 shows for the 84 cases, coiling had more favorable outcome compared to the clip. And when we ask the same thing for the long-term result in 2021 paper showing a retrospective analysis from 2003 to 13, it was around 1,000 patients. For the endovascular part, the initial occlusion rate was 86%. And in that case, only 10 cases had recurrences that needed to treat, and they were good. So 80% cases with a favorable outcome and 1.1% of the mortality in this series. So we come to patient selection. Whenever we want to select, as already described by previous speakers, important part is patient factors. There's age, clinical grade, comorbidities, and life expectancy. That is, if the age is more and life expectancy is low, or more comorbid patient, less invasive approach are more feasible, easily available, and also safe. And also aneurysmal factors like size, location, neck width, dome to neck ratio, incorporation of the vessel into the dome or neck, or presence of thrombus or calcification into the wall, and then numbers of the aneurysms. This we will deal on later in this presentation. Last and most important part in India nowadays, we have easily availability of the Google, and everything is on internet. So patient and family preferences are still a very important part in this decision making. Already microsurgery has been covered by my previous speakers and very well. I would not like to comment on that much part. Also, limitations of the same, I would like to say the dynamic retraction has decreased the amount of brain injuries, and as it is a exovascular procedure, perforator injuries are there, but with a better surgical advances and experience, it can be overcome easily. For the endovascular part, role comes when mainly for the blisters and pseudoaneurysms, which are surgically somewhat challenging. In unruptured cases with young patients, they are also a very good role. For giant aneurysm, for both endovascular and microsurgery has having the same problem, especially with the ruptured cases, because they are having a very poor prognosis and that part. But still, due to the advancement into the endovascular devices like flow diverters and intrasaccular flow diverters, it has become norms that we treat the giant aneurysm with that only. For the difficult access by microsurgical cases, when there is a recurrent aneurysm after clipping or multiple aneurysm, when single craniotomy or access to the same region is very difficult with the same craniotomy, then endovascular part is more used. Of course, it is a less invasive, having a rapid recovery, overall excellent safety profile. So usually preferred by patient and relatives. For the same, there are limitations. Main problem is a recanalization due to the coil compaction and later on again re-rupture. But in newer coil advancement, it is gradually decreasing, and with the use of stent, balloon flow diverters, and intrasaccular devices, these rates are gradually decreasing. Again, incorporated vessel into the aneurysm, either at dome or neck. It is also a problem for endovascular part. For that part, clip reconstruction is a very good option. But again, with the advance of the new devices, it can also be tackled. And in the ruptured cases, especially while putting stent or flow diverter, when dual antiplatelets are used, it is having the same limitation. But again, now advancement with the new flow diverters, the coating of the flow diverters, requirement of these dual antiplatelets are decreasing, and with the intrasaccular devices, we can usually say that after 15 days it is not required. So gradually it is reaching up to the normal clipping level. So actually, it is not basically a competition of clipping versus coiling. They are the different tools to treat the same condition. Basically, it is basically aneurysm versus the treatment modality. And again, I would like to say clipping or coiling or clipping plus coiling or vice versa. It is basically used only as a safety purpose and treating for the treatment of the same aneurysm. We go towards the cases. If you see my left side of the area, it is a 30-year-old female. A and C, you can see it is a simple clear-cut aneurysm. Whenever you start navigating from the femoral area up to this aneurysm, you will reach into the aneurysm, you coil it, and everything is done. Another case, a 32-year-old female, actually a ruptured case, but presented after 15-16 days. So it was now a normal unruptured case. We go into that, admitted on the Monday morning, and I coiled it and I discharged on Tuesday evening without any neurological deficit. Another is, sorry, my pointer is not working, I think so. So on the left upper area, we can see a bilobed aneurysm, which is enlarged image on the lower part. I did a simple coiling. I had to consider it to be two aneurysm rather than bilobed aneurysm, and did an individual coiling into each lobe, and it was gone. Patient is doing well. When there is more of a difficulty like this kind of aneurysm, we use a stent-assisted coiling. If it is a ruptured aneurysm, there is issue with using of dual antiplatelet is there. But in a part of the clinical practice where we are working, we don't have that problem with that. We go for any kind of EVD placement or even more surgical procedure with the dual antiplatelets already going on, and we're doing this. So we did a stent-assisted coiling. The middle image is showing a spiral is like a stent, and another part, that round part, is a coil. Patient is doing well. Some cases we require a branch to save. My left part, the aneurysm is showing that a branch is coming out of the neck of the aneurysm for the DACA part. In that, we put a contour device. It is an intrasaccular device. We put it. It saved a lot of trouble of saving the branch, and patient did well. Another case on the right side, we have to save both the branches. For that, we did again a contour device. It is a intrasaccular flow diverter. The most right side image is showing the beautiful contrast stasis into that, and it was cured. And antiplatelet was stopped at the 15 days after putting it. Now comes a more challenging part when aneurysm is multiple. Here you can see one ACOM aneurysm with that right side A2 segment dilatation with again a distal part, a DACA aneurysm. In this kind of cases, surgical treatment with clip reconstruction, I don't know how it will work or how much amount of clip we can use for this kind of cases. Putting a two-floor diameter were good choice. We put it, and the aneurysm was taken care. Patient was doing well. For the microsurgery and nightman, you clip the aneurysm, everything is good. After 15-16 days, patient care comes again with subarachnoid hemorrhage. Then you do angiography and see there is a residual recurrent aneurysm on that part. In this kind of cases, a flow diverter assisted coiling is the only easily available option, or you can go again with microsurgical perspective, put another clip. Usually patient choice is non-invasive in that part. So we did a flow diverter and coil. Here the spiral part is a flow diverter and the coil is itself we can see. So in short, take home part is since 1937 we are doing microsurgery for any aneurysm. We are good. Microsurgical perspective is improvising with anesthesia, neuronavigation, and microscope. Everything is there. Same way endovascular after year of 2000, and it is also evolving, gradually improving, and due to the availability of the new devices. So we can quote that now for any aneurysm, endovascular means can be used. Issue is in India is a cost that has to be always taken into the account, but at the end, follow the aneurysm treatment philosophy that it should be safe and outcome should be better, and use whatever you use. And lastly, if you are good at do microsurgery, do it. If you are good at doing endovascular surgery, do it. It will help the patient. With that, I would like to conclude. If there is any question, I will take.
Yeah, excellent presentation, excellent talk, Dr. Tushit. So there is
Thank you,
one
sir.
question. Actually, he has not posted any detail in this. So he has posted, sir, just a question, just a suggestion. I have a relative with DACA aneurysm. Should I insist for endovascular or clipping treatment? So there is no detail available. So this is a very tricky question.
See, basically, what is again for the layman person or the relative perspective, again, if it is a safe and easily accessible by endovascular mean, I will go for endovascular part only, because as I show, if it is a simple coiling thing, this can be done within half an hour to 45 minutes, excluding anesthesia time. And if it is not a ruptured aneurysm, you can discharge patient on next day without any deficit. So I think so that has to be taken account. Already I have shown every images that if it is a recurrent, multiple, or giant, or so I think so decision should be tailored to each patient's scenario for that one.
No, I would like to panelist for their
I
comment.
think I have many points with which I don't agree with Dr. Tushit, because you are quite politically correct, because this is a large neurosurgical gathering and you have made a lot of them happy with what you said. But when you actually, I will stick my neck out and say that this is not so, because you and me are not going to decide what we want to do. It is the patient ultimately who's going to take for it. I was a purely microsurgeon for last so many years. And since the time we started doing endovascular, whatever I may suggest, people come and demand from me to do endovascular only. And if we say, okay, you tell them residual, this, that, everything, residual neck, they ask me if there is a residual neck with endovascular. And at a later stage, can you still, if few years later I have a problem, can you still do microsurgery? What is the answer? Answer is yes, we can do. So they say, okay, then we will go for endovascular now. Later we will see what happens. That is the real true scenario. So then when I thought about it, I think we say as a microsurgeon there, these are the problems. We try to highlight the problems of endovascular surgery. We say, okay, residual necks are there, this is there, that is there. But does it actually translate into more rebleed rates? Do we have enough data to say these residual necks led to these many rebleeds? Or okay, we can say neck was there, aneurysm grew, but did ultimately patient comes with a bleed. Patient has a problem and it bleeds. Did the residual neck lead to increased rebleed rates? We don't have sufficient data to say it does. So that point is really, not a valid reason for us to deny them a coiling or endovascular treatment. Clipping, definitely we know we are good surgeons and we have seen even better surgeons than us doing good clipping. But when you compare the morbidity and the post-operative recovery rate of a surgery compared to endovascular, there is a huge difference. Tomorrow, me and you, when we have a aneurysm, suppose we will also go for coiling from a good place or a good hand. So ultimately, patient is going to have decide. We may opt for something. You say we had a conference and two of us decided. Patient is not going to listen to what you or me decided. They will go for what they think. They have the tools to or the means to find. They have Google. They have all the data at their tips, and they are going to decide for coiling. So what future is going to hold for us is most will be coiled. We know that most aneurysms at all sites will be coiled, and complications of coiling are going to come for surgery. So most of the microsurgeons will be very good. We are good, but we'll be better because we will be handling complications of coiling. We are going to ultimately go for that. Our experience is going to take us there. So both will coexist definitely, because whatever problems of coiling will be taken care by surgery. And then post-coiling, so many surgical scenarios like hydrocephalus, hematomas, this, that, everything we are going to, as a surgeon, we are going to tackle them surgically. So both are going to coexist. So why I'm saying that is I have personal experience. I went to Helsinki in 2009-10 when Professor Juha was at his peak. Their clipping rate was 100%. There was no coiling allowed in Helsinki hospital, whereas in France, inside Europe, Jacques Moret was doing 100% coiling in his center. And European patients who do not have any access problems, who have European Union, they can travel without anything anywhere. So people who opted for clipping used to go to Helsinki, and wanted to go to coiling used to go to Paris. But the Helsinki center was 100% clipping center. After he retired in 2016-17, I have been there in 2021 also. The same Helsinki center, which boasted of highest number of aneurysm surgeries in the world, was doing 60% coiling. That was the difference. That one person was not letting it go and everybody was following his thing. But in India, we have a free democratic country. Nobody has the control, and especially surgeon cannot decide at all what patient is going to ask. So ultimately, they are going to go for coiling. That is definite. Now we need data for this, the complications of coiling, like residuals and regrowths. Does it translate into rebleeds or patient morbidities? That data is still, under process, and we're going to, once we get it, then we can, okay, maybe say, somebody may say coiling, clipping is better for this particular aneurysm. Why did we surgeons leave basilar aneurysms to coiling initially? Many years back, we stopped doing because we had problems. Our results were bad. So most of them were allowing the endovascular guys to do it. Endovascular guys slowly, picked up, they became better, and they have replaced most of the things. So uh, we should not shy away from, it's not clipping versus coiling exactly. It may be, but ultimately clipping and coiling are going to be done by the same guy. That is the future. I think all of us neurosurgeons, as well as our residents, I am a late starter in endovascular. I agree. I am, but the people who are in training, they can either undergo endovascular training right now, or immediately once they finish their degrees, they should go immediately rather than doing anything else. First 1 year or first few months, they should put in that. The learning curve of endovascular, I'm sure we all know, it is much shorter and much easier. Learning good microsurgery took a long time and it is very difficult. Coiling is once we are a surgeon and once your hand is good in microsurgery, coiling is nothing for us. So I promote to all our viewers and all the people who are, our residents and people who are listening, try to train yourself in endovascular side by side. It is not difficult. Once you have both the things, it's like having a shotgun is better or a machine gun is better. There is no comparison. Some things, this may be better, okay. But if you have both the guns, you don't need a guy for that and guy for this separately. No, if both the things are in your hand, then you are the master of, I think, the neuroscience. That is my take on this clipping versus coiling debate.
Sir, I agree with you.
agree
that-
completely. I agree
Pardon me
completely.
for 1 minute. I agree with you on that part that we actually don't have that exact data that how much of that is a residual part and how much that is going to bleed or getting in the bleed. Again, see what happens is this whatever I have told is only on the paper-based data. Okay, in regular already practice of last 9 years, I am doing both the thing, clipping and coiling, and judicially providing all the data to the relative first, and whatever they choose, we go ahead with that because we have a team and it is doing in so. And I totally agree with you. The endovascular part in that area is evolving very fast. So as already I mentioned, a problem of dual antiplatelets, wide necks, giant aneurysms, everything is being getting solved on that part. And we are having a very good results on that part also. And again, I would agree that a dual trained surgeon is better in that part because sticking only to microsurgery or sticking only to endovascular, it is not going to be a solution in future part.
Yeah, I agree, sir. One problem which I fear, which I see, is that you become an average microsurgeon and an average coiler, and that is what will affect tumor surgeries, everything else. For probably Jaspreet sir, it is different because he was a very good microvascular surgeon first, and then he went into endovascular or did something else. Problem with the current situation is we learn neither microsurgery nor endovascular properly, and we end up doing everything so badly that when the recurrences come, somebody was talking about clipping of coiled aneurysms. If you have actually clipped a coiled aneurysm, it is one of the worst experiences of your life that you will have. The aneurysm wall is gone, clip doesn't sit, it is completely shaggy. Once you start pulling out the coils, neck comes in your hand. It is a disaster when it happens. So we are going into an era in which uneducated patients are taking uneducated decisions for situations that they don't understand by surgeons who are neither well trained in either situation. This is the situation that we are going
Sorry
into.
to interrupt, but I am not agreed with you.
Same,
Is
I am
the
also not agree
coiling
with him.
coiling is not the rocket science. Most of the coiling the radiologist people are doing or neurology people, are you thinking they are better than us?
That is not the
No,
case,
no.
sir. But the problem is we are neither good that way,
Either they
neither
are
that
better
way.
than us. I don't agree with you.
Yeah, coiling is nothing. It is very
Okay.
easy.
It is not
Yeah.
rocket science.
See, sir, if I may.
If you are able to do any this neurosurgery, you are able to do the coiling also.
Coiling anybody can do, definitely, Harsh.
you are going to be better than other persons.
Yeah.
No, sir, I am not comparing
Other
ourselves
specialty.
with radiologists at all. I am not
Yeah.
comparing with them. I am just saying ki whatever you are doing, get good in one thing first and then go for the other thing, rather than being average in either one of them.
I don't know, Harsh. See, I have done first coiling after doing 650 aneurysms clipping.
That is why, sir, you have.
I was so late, but when I did, I thought, oh, why did I waste so much time?
Because
This is
you did
nothing. I could have
650,
done it
sir. That is why
2
you were
years
so
back. It
good
was,
at it.
agreed. Microsurgery needs the training, that hard work, everything. There is no escape from that. If you want to be somebody wants to be a good microsurgeon, they have to do it. Only coiling is nothing. So we should not leave coiling thinking it's
Yeah.
something new when I am microsurgeon.
Absolutely.
Coiling is nothing. It's our little finger
I-
job. We can do it.
I think
All of us.
coiling may just decision making is the most important thing.
Yes.
It is not doing in which aneurysm what you are going to put. What that is the most important thing. It is not that you are not able to do, or you are not. It is not the. I don't
Yeah.
agree with you.
Technique is not difficult. So
Yeah,
we
the
can.
only problem with this
Only
is that
decision,
we are
only decision
producing.
making. What hardware you are going to put it?
Sir, I mean, the vascular handling that we develop, clipping aneurysms, that thing is going to go away soon, and that will reflect on the results of our tumor surgery and even everything else. The level of
Harsh,
microsurgery overall will come down dramatically, which
I
has
hope
already
not.
started coming down. Actually.
so
It will not
can
come down in our lifetime, probably.
If
We
it-
will not be alive to see it.
even if a microvascular surgeon wishes that I am going to do all the clipping or everything, it is not going to happen.
Yeah, that is what I'm saying, sir. Because the
In
market forces
Rajasthan,
dictate.
in
Yeah,
my
market
state,
forces.
listen, in my state, the treatment is free for people. Even coiling is free. Stent assisted coiling is free. Balloon assisted coiling is free. Nobody wanted clipping.
Imagine the state of the
Nobody
surgeons,
chooses
sir, I mean,
clipping.
after
Even
some
if you,
time. Imagine the state of the surgeons who are getting trained now, sir.
even in MCA aneurysm, you know that clipping is better. You offer them clipping. Bhaiya, ye clipping is going to be better in this case, but he refused.
No, sir, I'm not talking about the patient perspective.
No,
The
no.
surgeon perspective. Uska kya hoga? Who is getting trained now, who has never seen an MCA aneurysm in his life.
can I make a comment here?
Yes,
I think
please.
What
Yeah,
happened about basilar artery aneurysm?
That
How
is what, no,
people-
sir. Nowadays, if you ask someone to do a basilar artery aneurysm
if
clipping,
you even wanted to wishes to that you're going to clip the basilar artery
yeah,
aneurysm,
yeah. So that art is dead now.
no, so
yeah. See,
that's why.
That art is
I think
completely dead.
Harsh, what I think
It is
Sir
not
is
dead,
making a
means
valid
people
point.
are still doing it.
Yeah, people are still doing it. Those are those people
It
who
is not
did it
dead.
previously.
The
People are not doing, and people who
endovascular
are starting to do now, they have now
endovascular
adopted it.
endovascular surgery's hardware is so becoming more and more advanced. It become better, going to give better and better results.
Absolutely, sir. I completely
And
agree with you.
Yeah,
clipping
Can I?
As the rapidity at
lesser
which the
amount.
endovascular equipment is getting better is the rapidity at which the microvascular is getting worse. It's as simple as that.
Harsh, Anil, can I make a point?
Yes, please. Yes, please.
See, this is an eternal debate, and I think as surgeons, we are losing this battle. You have to understand this. So there is no, shame in admitting that as time goes, the incidence of clipping or the availability of clipping, coiling is going to be much higher than clipping. Clipping is going to go down. It is a difficult art. You have to spend a lot of time, and number of cases are decreasing. So the need of the hour is to accept that endovascular is going to stay and is probably going to occupy a large amount of space in the neurovascular treatment of aneurysms, and clipping is going to remain limited. So the need of the hour is that as neurosurgeons, we have to learn coiling, understand that. And I have always believed that you can never be a true, genuine all-rounder, right? Everybody wants to be Kapil Dev. I also want to be one, but I have started realizing, do you know Michael Lawton is a dually trained neurosurgeon? Have you ever seen him speaking on coiling? He probably doesn't. So what I want to tell you now, in the single department, you should have people who are doing coiling as well as clipping. Suppose I am somebody who does all the clipping. I should have some other guy who does all the coiling. But the neurosurgeon has to be doing it because decision making has to be unbiased. Right now, what is happening is the coiling that is being done by our radiology colleagues, the way they counsel the patients, it's sad to say, but the neurosurgeons under such a bad light, as if that we know nothing, and if we operate the patient is going to die, which is not the case. Most of us are gifted neurosurgeons, and you have to come and visit us to see what we are doing. So the thing is, in the same department, you need to have people who are doing clipping as well as coiling. A judicious decision making can only be done by a neurosurgeon, who knows both the sides. Even though I may not be good coiler, but I know that my ex-colleague is going to do it well. Similarly, he knows that I'm going to take care of a difficult aneurysm that he cannot coil. So need of the hour is to understand that coiling is here to stay. Learn coiling, not necessarily yourself. Let it be somebody else. I would prefer to be a pure batsman. I don't want to become an all-rounder. This is my take is. I'm going to allow my friend to become a perfect seaming bowler.
If you want
And I'll take care of the batting, right?
Yeah.
But the decision has to be by neurosurgeon, and be it patient, be it treating doctor, you have to accept coiling is here to stay.
Yeah, absolutely.
What I wanted to say that nowadays, if you wanted to choose a cerebrovascular specialty, You are incomplete if you are not knowing the coiling, how to do coiling.
Yes, absolutely. But
If
I would
complete-
still add, sir, microvascular or microsurgical technique has to be learned
Yeah.
before you do put in yourself into coiling.
Mhm.
Because the problem is, if anything comes, you will shy away from doing the hard job and put coils in everything and ultimately not learn. It is like urology, what has happened. Open urology is dead. It is only robotic and lab that is happening. The day someone has to open an open urology case, they shy away from it because they don't know how to do it. They have never done it in their life. Same thing is going to happen to ACOM, what has happened to basilar. At some point of time, ACOM clipping is going to finish because we will be so scared of doing it because everything is getting coiled.
Can I
Jay,
add some point? Can I add some points?
Yeah, Sanjeev, please.
Yeah, as Kuntal said, that debate is eternal. That's true, absolutely true. I just want to make some point about recurrent aneurysm, which small data is available. There are small case series. Actually, we had a case of recurrent ACOM aneurysm after clipping. So we want to write a paper on it. So we digged out the data. There were small series, and we when combined the data, the chance of rebleed was actually higher after coiling, recurrence and bleeding. But that is not some sort of meta-analysis. This is just a gathering of data and summing it up. The problem with the coiling and clipping debate is that both data are not grade matched. I think everybody will agree with me that the patient outcome mostly depend on what patient you get. If you compare the unruptured aneurysm with the poor grade aneurysms, it is not a perfect comparison. For recurrence or residual lack, what I feel, and I have heard many people talking about it, the aneurysm surgery cannot be a getaway treatment. That for 1 year, the data is showing that coiling is better or clipping is better. But for long term, both are equal. So that getaway treatment is not a good thing. Regarding the posterior circulation aneurysm, people consider that basilar top aneurysm, that coiling is definitely better than clipping, as previous studies have shown. But I was just want to tell you that just to dig out a paper from Turkish neurosurgery, it is probably in 2022 or 2023 published, a meta-analysis about clipping versus coiling in a posterior circulation aneurysm, and especially basilar top. And they showed that initial results were much better. Initial results were better for coiling, but again, the long-term results were not different. So these are my points to make. Anybody want to counter me on that? I will happy to answer.
Completely agreed, Sanjeev. I think
Agreed. This is
there is
nothing to
no
counter in
two
that.
ways
Yes.
in it. Yeah, I think Jaspreet sir has very rightly put it forward. We have to learn it. Same team has to decide, unbiased, and we have to trust each other. And I would say, rather than going for an all-rounder job, I'll prefer to specialize in one area. Let my colleague do it, but the colleague has to be neurosurgeon, no doubts about it.
Yeah,
I
that is
trust
our
my friend's
personal
neurosurgeon.
preference. Yes.
Let me tell you one more practical point. In our place, mostly the endovascular thing is done by interventional neurologists, interventional radiologists, and there are neurosurgeons who are doing an interventional coiling thing also. But that is a practical thing. If the patient comes to me, a neurosurgeon, I give them two options: coiling or clipping, whatever you choose. This is the advantage of this thing and that thing, and disadvantage of this thing and that thing. But what I have come across that this interventional radiologist who are not a neurosurgeon or a neurologist, even the neurologist, they just tell only one aspect of the option.
Yeah, that's
And
true.
they tell like that, इतनी बड़ी खोपड़ी खोलनी पड़ेगी, इतना बड़ा चीरा लगेगा, ये लगेगा, वो लगेगा. That's what they talk about. But what I counter them, that skull opening तो हम लोग जो कैनियोट भी तो हम लोग 100-200 साल से बना रहे हैं. अगर skull opening से कुछ होने होता तो nobody would have survived. But that is the way they counsel the patient. So that thing I don't like actually.
Yeah, sir, this is the reason that I said that we have to take hold of the whole thing. We have to take the bull by the horns, do everything ourselves.
Yeah, same.
Ourselves doesn't mean one person. Okay, as Harsh wanted, okay, he wants to be in one thing and his colleague wants to be another. That is our personal preference, how many people we have and how we want to form a team. If one person wants to supervise everything and, you know, and one, or we have different members to do different things. It's personal decision. Somebody wants to do only cranial and somebody wants to do only spine and somebody wants to do both cranial and spine. Cranial and spine also have nothing in common, you know, as clipping and coiling doesn't have. Cranial surgeon and spinal surgeon can be different, or it could be the same person. So it is our personal preference. But I think
Yes.
we should not leave it to another guy to, you know, take the call, especially when they have a chance of misleading or they're being biased and, you know, take a decision in a biased manner. We would be in a better position, definitely. That was
Absolutely, sir.
Yeah,
Completely agreed.
perfect. So
Completely
now I
agreed,
think
sir.
it's time to wrap up the
Yeah,
webinar.
just one more question, Anil. I just want to ask the panelists the complication of endovascular treatment. Does anybody feel that is much underreported that actually are than actually are?
No, I don't think so.
I
There are less complications. Complication means immediate intra procedural or immediate post procedure complications are less
As a
in endovascular.
neurosurgeon,
That is my
as
personal.
a neurosurgeon, you are better to handle the complications. Even if
Yeah,
there is
maybe that is the
sudden,
reason because we ourselves are handling the problem, so we
even
don't.
if there is intra procedure rupture, you just go and clip that, open the cell, skull and clip that, do ICS removal, everything you can do it.
Yes.
Thank you,
That
sir.
there
I think we
at
need
that
to.
place the neurosurgeon has an upper edge on all these people.
Always upper
Definitely,
age.
definitely.
Always upper age.
Yeah, I think this is quite acceptable as our neurosurgical colleagues are saying. I any day would take it on at the face value coming from a neurosurgeon rather than a radiologist, because I have personal experience that sometimes they will underreport it, but not our neurosurgical colleagues. We are not built that way. We were dead honest people. Yeah.
I would like to just add that at my center, I am in a private sector. In a same city, we have 3 hospitals. All of the 3 is managed by us only. We are total 3 neurosurgeon and 2 more junior neurosurgeons. And that we have already divided our specialty in that part. If I am doing a neuro intervention for a stroke, and after that there is a bleed, then usually my colleague will go and operate for the decompressive craniotomy in that part. So that team is working accordingly, so that better outcome will be there, and there is no hassle for only one guy to do everything.
Okay. Okay, can I, Dr. Anil? Hello, am I audible?
Yes, sir. Yes, sir.
I thank Dr. Harsh, Dr. Kuntal, and Dr. Tushit for their lucid presentation. And we have very good panelists, starting from Dr. Jaspreet, Dr. Gupta, and the other panelists. We had a very good session, and this debate will continue. But as Jaspreet mentioned, the time has come that we should learn endovascular. Otherwise, this debate will continue till your last breath. We have to stop somewhere and start learning the things. And Dr. Gupta mentioned, absolutely, I agree with him that reports are very less complications. So by these discussions and all, we can evolve ourselves. With this, I congratulate Anil also for arranging for a beautiful webinar. Thank you all.
Thank you.
Thank you.
Thank you very much. Good night.
Thank you.
Thank you very much.
Thank
Good night.
you. Bye bye.
I thank all the panelists and speakers and all the participants. We had a wonderful discussion about DACA aneurysm. Thank you. Thank you very much. Thank you.
Thank you.
Thank you.
Good night.
Good night.
Good night. Good night.
Hi, Jaspreet. How are you?
सर हेलो गुड सर मैं
Very
अच्छा हूँ
good,
सर
very good discuss. Very
मैंने
good
सोचा
thing.
मैं आपको देख लूंगा आपकी मुझे शक्ल नहीं दिख
नहीं,
रही
मैं actually I was in a difficult situation. Anil knows my father
Okay.
is not well, so
Oh.
I just tried to be there. Otherwise,
ओके ओके सर हाँ
thank
कैसे
you.
हैं सर
Thank you.
अदरवाइज आप ठीक हैं मैम ठीक है अच्छी हैं
हाँ, sir. Good night. Good night.
यस सर बाय सर टेक केयर सर गुड नाइट
Okay.